So there's dairy, there is fiber, there is variety. What's important in sattvic diet is variety. So you get good combinations because with all these diets, the Mediterranean diet, the mind diet is all about the Mediterranean and DASH together. DASH is a diet for hypertension. If you look at a common pattern, same. Sabji jada khao, normal fats khao. So if you start looking at how the diets have been worked on, there are a lot of good fats. There is definitely a dairy allowed. The lentils are less. The non-veg is more of a less fat non-veg. The fish special is given. So that's why Mediterranean diet is proved in every area, neurodegenerative to your NCDs to everything. It is proved that it works. The mind diet says more promoted because it has a lot of fruits and vegetables. Mediterranean diet doesn't have a lot of fruit, only 1 cup or 3 per day. But mind diet says 10 fruits and vegetables every day. So end of the day, what does this diet do is they're helping me to eat more of colors in my diet. So why not try my Indian traditional diet? Indian traditional diet gives me vegetables, dals, ghee, chawal, everything in a balanced amount. I wanted to give you this kind of a meal, sitting in one place and eating this meal and see how you feel it. And this is how an Indian ICMR plate talks: half fruits, half vegetables. Then you have pulses, nuts, oils, and the grains which are mostly complex. So again, what we're trying to do is dal chawal roti sabji. The definition is changing in a different way. This is anti-inflammatory diet. We also have in ICMR N9 guidelines an anti-inflammatory diet. A lot of promotion of millets is being done, but millets in more of absorbable and bioavailable form. How you can make, because millets have a lot of goitrogens and a crude fiber. So just eating millet like that may hurt your digestion, gut may be it'll give back to you. So millets, if you have, South India has the fermented ragi ball or mals. We also have ambel in our culture. North India has sattu. So if you soak, sprout, roast, you have a better bioavailability of the food and the anti-inflammatory factors improve. So you have again good amount of vegetables, and anti-inflammatory diet is something where you say that do not include processed food, the dairy, the gluten. So elimination diet, when you want to go on an anti-inflammatory diet, you eliminate 5 major challenges of your digestion and then go on a sattvic diet, a dairy-free diet. Every week start looking at your symptoms, at your gut. So you are definitely there. So there's the Paushtik Ladu is any day better than energy bar. How do you take that? Yes. So that's promotion where I think all of us have to be involved in. And for a sportsman, when they say they carry energy bars, and definitely when they go to competitive sports, we used to ask them to. But from everyday sport, they can always have their color too. What's important is mother has to make it. So it's all about convenience, comfort, and making it applied. But there are a lot of channels available for us to get there. Dash diet, lot of vegetables, fruits. This is how the Rajas. I think I'm not an expert to talk about it, but yes, we need to integrate. I was talking to Ambekar sir that how can a modern dietetics? It's the time like physiotherapy, yoga have to integrate. Like that wise, Ayurvedic dietetics, because this is now gaining a lot of importance, where the researchers are proving that sattvic diet, rajasic diet. But as a modern dietetic person, I do not know what kind of diet to give whom. So I'll boil down to my nutrition from portions and carbs and proteins and try to balance with that. But definitely when I've spoken till now, I've spoken a lot of integration. I've started talking about that you need balance, you need combination, you need phytonutrients. That's what I think these diets are doing. And we will wait for the integration to help us to standardize a sattvic diet for our country. And I think then we have a long way to go. So a small, again, I need to validate this too. You can, in the break time, you can do that. You have this questionnaire. You ask yourself where you stand, right? Where is your height, weight, BMI, for circumference? If you have them, but height, weight, BMI can be found out. Any deficiencies you have observed with yourself? How are you in eating pattern? Normal, irregular? Be honest to yourself. You're not going to judge anyone, or you're going to judge yourself, which is for your own benefit. Do you do exercise and you sleep well? And score yourself and see how you really, because everybody can't do it by themselves. You do need a therapist. And you should take their help to streamline your mind, streamline your health. Like it's like a very good student who can do 100% academics with a teacher. Somebody needs special classes, somebody needs too much special attention. So you have to categorize where you fall into. And I think this is what is the term nutrition literacy is the way forward. And I think we dietitians are responsible to contribute to that society and to that what we can work on. And thank you, Vaishali ma'am, because of you I could connect with mind, which we never did in our academies. Thank you very much.
House dietitian, because she never cuts off any food items like by anybody in the house. She'll always suggest a good change and a good way to rectify that diet. So I think all my patients love her in terms of her dietary advice, because children can eat their pizzas when they want, then they can eat their chocolates, because she has a very tricky way of prescribing these things, and still kids are following the diet very strictly. So thank you, Geeta, for making it so interactive, and I think it's a vast topic covered in a very short span of time, and I'm sure that nutrition workshops are going to go ahead whenever you take into nutrition seriously. And I'm seeing a lot of dietitians endorsing that, so that's also a good thing. I just wanted some points from an endocrine perspective that I would like to add. First thing is that we have a switch in the room. You have a light on, off button. You have a pacemaker in the stomach. So when you put a pacemaker, the button is on. So the machinery gets geared. So whether you put water or food or calories or anything else, once it weighs, your stomach senses something has come in, the button is on. So your machinery is on. So your hormones start functioning. So your insulin starts rising. Whether it is water, it is sweet water or sugarcane juice or whatever it is. So body is very insensitive to what type of food you are taking. It is sensitive to the weight. So if you are eating 1 liter of food and you are eating 1 liter of barfi or peda or 1 liter of water, that is what the body is going to sense as equal. So 1 liter of water will also produce the same kind of change. The only thing is that the caloric content of this food is going to be different. So it is advisable that, as Geeta rightly mentioned, taking the protein-rich liquids and protein in the bigger portions in the early part of the meal makes a lot of sense, because proteins have a benefit of satiety inducing, plus the weight of that liquid, plus the quantity volume of that liquid. So, and one more habit which I think that most Indians, I remember in my childhood, not everybody had breakfast. So that has been a habit induced with breakfast cereals, very lot of oats and all. And I still see a lot of patients who tell me that I eat in the afternoon directly, and I'm okay with that. If your body is okay, because each one has a circadian rhythm for food. So we spoke very less on circadian rhythm in this workshop, but it's a huge one-day coverage of all the rhythm, and appetite has its own rhythm. So if I am hungry only once a day, I can still eat once a day because my body requires it once a day. But if somebody is hungry every 4 hours, you can't tell that person to go on intermittent fasting. That person needs to eat because that's the biological clock of that person. So breakfast is not a mandate. Eating is not a mandate. Breathing is a mandate for living. So how much can you survive without eating? What is the maximum days? 28 days to be exact. So if you don't eat today, you can survive with whatever is existent in your glycogen storage without going into starvation, ketosis and significant problems for 28 days. But people have done this for 3 months and thereafter also. So eating is not a mandate. And lesser you eat, the lesser you burn your metabolism and your GI, and more you preserve it. So eating less is always healthy. So again, as Geeta rightly mentioned, the portion size matters more than what you are eating. So you are eating, say, unhealthy food. You eat a small portion size of unhealthy food versus large portion of healthy food. This is better than the second one. So portion size matters. Second important thing which I follow in my diabetic practice, all of us must be following, that we ask them to take 1 portion of carb, because the Indian traditional diet has pori, varan, bhat. So there are 2 things which patients take, 2 chapati and 2 servings of rice is what commonly people tend to eat. So I tell them that the easiest way to cut down the portion size is take only 1 of the carbs. You take either bhakri or pori or bhat. So you are allowing them to eat whatever they want, and I'm sure that they would not increase the portion size when Geeta is giving so many other stuffs to add on. So all these tricks do help in practice. And third important thing which I think is lacking in the Indian traditional diet is fiber content. And that fiber content has to artificially be introduced or increased. So One way is through increasing the veggies, salads, but there are a lot of people who don't like vegetables, they don't like salads, they don't like greens. There are mothers who complain that my child has never eaten a vegetable. And in such a situation, we do have soluble fibers now. So what we tell them is to add on soluble fiber to the water with every meal that they take. So first important thing is that they need not eat thrice a day. It's not a mandate. It has to be decided by the circadian rhythm. Second thing, important thing is portion size has to be less. Third important thing is the way Geeta has mentioned, the eating pattern defines most of the thing. Fourth important is home food. But home food conceptually has to be health food. It is not so in the current days. People will make Chinese burgers, pizza at home and say this is home food. That doesn't make sense. So it has to be healthy home food. And one more important point from an endocrine perspective is it's a physiology of BMR that every decade of life the BMR cuts down by 50%. So it is necessary that with every 10 years that you pass in your age, you have to cut down your appetite by 50% and increase your exercise by 50%. Otherwise, your BMR is going to make you put on body fat every decade. So, especially in menopause, this happens, and that's a common time. It happens at pregnancy, postpartum, menopause in women, and it happens after 40s and 50s. You see, all the males, they start putting on their belly centrally. So, this is what inevitably is going to happen if you don't cut down. So, traditionally, आपले ऋषी मुनी किंवा वानप्रस्थात जाताना they eat more raw food. They never ate cooked food. The more cooked food you eat, the high chances of obesity. Less cooked food, less heated food, more raw food, the better is the chance for hormonal health and longevity. So now most of my patients would say, दात नाही, हे नाही, ते नाही. I tell them mixer मधनं काढून खा, porridge करून खा, शिजवून खा, वाफवून खा. So whatever they can do, they should follow. And I think these eating principles carried on for life will always help. And one more thing which I tell a lot of executive people is that there is a habit of intermittent eating when I'm at the computer, when I'm at the desk, and when I'm doing some work. It's a reflex action. Even we saw here that we did that very reflexly. So the commonest health food to have during this time is water. So having plenty of water, as I told you, body senses the weight. Water has two benefits. It is known to suppress the vasopressin. So vasopressin is an appetite suppressant also. So water has an effect on food intake. It is known to increase satiety. It is known to also help in improving the weight of food. So body is a very good calculator. So you are taking 5 liters of food daily, it will take that water into that 5 liters. So you will be eating less portion size and you will get the same benefit of excess water intake. And of course, water also has a thermic effect. So it is known to increase the BMR. So water is very useful for these kind of techniques, and these are tricks or hacks which can really work. And what warm water does is also helps in inducing satiety. So cold water is known to increase hunger. Hot water is known to decrease hunger. So you decide on what you want. Usually children tend to take more cold water and eat more. That is the kind of habit forming. So water is working through various mechanisms, but these are predominant eating mechanisms. So a lot of questions I am seeing for Geeta and a lot of suggestions. So Shilpa, you wanted to talk desperately since past
Actually, thing is, I have both like Ayurveda background and modern nutrition background. So there is like so much confusion, when these two things always going on, what should be followed. Ayurveda says we have to start our meal with something sweet. Madhura Amla Lavan Patodikta Kashaya. And modern science says that we have to start like what Geeta shared, right? So I was in so much confused mind, what should I give to my patient? And I did research as a clinician. I gave the same person modern nutrition. I calculated how much food he is eating, and then I actually gave the next week this Ayurveda type of diet. And then I saw the difference. There was a significant difference in food intake in both case scenarios, but there was one factor which I realized was how that person was able to digest, metabolize food, because we are not just what we eat. We are what we can digest and metabolize in long run. So for sustainable results, Ayurveda work better. But again, there was one more catch. Ayurveda way worked only if mindfulness was paid, it came into picture. For her method, people who don't have mindfulness, they can easily adopt to that method and are able to reduce overall calorie intake. But to reduce calorie intake in terms of Ayurvedic food, there has to be your mindfulness connection with what you are eating and how much you are eating, and they have to actively reduce their food intake. Then only in work. So that's what my finding was. Second thing about water, we think that water is something we should be consuming more and more is better. But Ayurveda, it's completely opposite. If you drink water before you start eating food, it's going to dilute your digestive fire. You will not able to actually metabolize whatever going on next one. And of course, I understand your point of view because, stretch receptors in the stomach, that's which is going to send the signals of satiety to the people. That's why, mindfulness is important. Ayurveda principle is you have to keep half a stomach empty. If you can't do that, of course, we have to rely on something external, that drink water and everything. And warm water actually increases digestion, and cold water suppresses digestion because it increases kapha, meda. So there, I have a patient. I would like to share her story. That she was eating very less amount of food, calorie intake, protein intake, everything was perfect, but she wasn't losing weight at all. And when I got into details, she was drinking a lot of water and she was directly drinking from fridge water. And only that factor changed, that she has to drink warm water and limited amount of time. Not like whenever she wants, or 2, 3 liters, 5 liters. Only that factor helped her lose weight very easily. So these are, something you have to integrate. And there is nothing wrong with modern science or, Ayurveda, but personalization matters. So that's based on my clinical practice I wanted to share.
This is true for everything that we discussed from day one, that the individualization of these factors is the key for everything.
And mindfulness, your mind is very crucial.
We are talking
one
mindful eating.
And
I just want to
एकच कमेंट आहे की सावकाश जेवणे याला अवकाश पाहिजे, म्हणजे पोटात अवकाश राहणे ही सावकाश जेवण. हो, आणि this point is very important. What I usually tell my patients is that the pace of eating matters a lot, because the brain takes at least 10 minutes to sense the satiety signal. So you see that when the patient is eating within 10 minutes, the chances of sugar rise, the chances of putting on weight is very high. So the fast eaters are the ones who get the weight gain. The slow eaters are the ones who are absolutely satiety. Even today we saw that if you take a soup and salad and you wait and sit and talk to your friends, and then you are full by the time you're taking your plate. So that's a very common happening, and most of the time what happens is that, as you were talking about mindfulness, if you have something, most of the people read or see their phone or see the television and eat. And that is the thing, that they do not realize that how much they have eaten. And within 5 to 10 minutes, you have consumed a huge quantity. And then the next time, the fact that you were telling me, the cold water is known to be heavy in digestion. In modern science, what cold water does is it increases insulin. So it makes you feel more heavy, and insulin is a water retaining factor. So it will make the person bloat, get edematous, you will get pitting edema. And you'll get these patients who always feel bloated and heavy. They are like wet sponge. They feel zard vatta thanna. So why they feel zard? Because they are like soaked sponge. And the moment you give them warm water and tell them these tricks of increasing BMR, it's like squeezing that sponge and making them lighter. So this is how that weight loss helps. But that is not the true weight loss. It's not the fat loss. It is mainly the water loss, which is happening in this mechanism. So I think that all these principles known to us, we have to design our own way of advising a diet to the patients. And I usually tell in simple language, 5-3-2 खेळ खेळता तुम्ही. The 5 portion fiber, 3 portions proteins आणि 2 portion carbs. आता कोणी हे पाळत नाही. So I'm sure nobody is going to stop at 2 portion carbs. But even if they eat 1 extra, they will follow a good diet. So it is better you tell them that एवढं सगळं प्रत्येक meal मध्ये follow करा. Even if you are eating pohe, even if you are eating upma, see that it comes with pastil though. So you have a salad, you have a fruit, you have a cup of milk, and then you have a small vati of poha or upma. It's fine. So that is the way if you can really convince your children, patients, or family members, it's going to really help.
Just one question, because most of the time when we say that we should rely on interoception, the problems in disease is that your sensors are at fault. That is the issue. That in blood pressure, basically it's the baroreflex sensitivity that is at fault. It is not able to work in the range in which it is supposed to work. So body has to increase the pressure in order to maintain the hemodynamics. So when the sensors are at fault, then how we are going to correct that?
Identify the area of problem in you.
Yes.
You have to ask, where am I going wrong? Either it's snacking or it's volume, unmindfulness. And then I think these are the tools which we can work, because we can't do anything to censor. Of course, it's a very slow and
Because see, if my stretch receptors are at fault, I'm not able to get the idea how much stomach is stretched.
here this kind of mindfulness tools and all this what we discussed for 3
So,
hours should help.
Should we have to think about that from that how we are able to make the corrections in the sensors?
This is what she spoke about, what she said and what she said. Those people who are mindful can follow this kind of a diet, which she said, the Ayurvedic type of diet. But those who are not mindful are really helped with the diet which she said, because there you are eating by the balance of portions, the nutrient value. You are not eating by the likings or the choice of the patient. The patient is eating protein first, then fiber, then the carb, and then the fiber. That kind of a pattern is going to be like a mechanical help to that patient who is non-mindful. So we are accepting that the patient is going to be blunted in terms of the sensations. Why are these patients?
But how then they get the satisfaction?
No, but then they will eat less. If they are non-mindful anyways, if they continue to eat carbs first, they'll be more unhealthy.
We are not asking to eat less. We will just follow the pattern, eat till you are satisfied. So the portions are only changing, the ratio is changing, but you can keep eating. You eat 3 bowls of varan.
Satiety goes very high in such patients. So I feel satiated when I'm eating a huge portion of food. So, but even then, if you're eating the right type of food, you will have less of imbalance.
We are doing early satiety, delayed gastric empty. So these are 2 tools we are following, so that your intake becomes more monitored and controlled. So these are few. The food can be used as a tool here, which is what we've discussed.
Actually, mindfulness is a very good idea here. The thing is that मैं अपने patient को simply कैसे सिखाता हूँ. वो बोलते हैं पता है कैसे चले कितना खाना चाहिए. मैं बोलता हूँ 75% खाना है. तो जब पूछते हैं 75% कैसे पता चलेगा. मैं बोलता हूँ कि पूछता ना कितना रोटी खाओगे आप सोचने लग जाते हो. तो that is 75%. So you have to stop there. That is mindfulness. So when you think I should take or not to take, मेरे पेट को ऐसा लग रहा है भर गया लेकिन थोड़ा सा और खा लेता हूँ. You should eat 75%. With that, a habit will come. With the mindfulness, you will get the healthy benefits. The sequence can be same.
Actually, mindfulness, the tool she told, it works much better.
Leptin and ghrelin rest. Comments on that?
Approach I am giving you in this. How much to eat? This is from experience, and this is from elderly Vaidyas. So, what they say, when your stomach is empty, you start eating. What happens is, after some time, you get first burp. That is one. Normally, it is one. That is normally 50% of your stomach capacity. And after that, when you keep on eating, then there are 2 burps. And when you get 2 burps, normally it is 75%. So you should stop at that moment. Normally you will not find any problem in your digestive capacity. So when you are perfectly, there is one simple rule. Tanmana bhunjita. You should be with your food when you are eating. Then only you can elicit this 1 burp and 2 burps. And after that, after 2 burps, if you are keep on eating, you get 3 burps, 4 burps, like that. You try this, what I am saying, tonight or tomorrow morning. So you will be able to say this is what I am saying.
You can't keep on watching TV while eating, otherwise you will miss it.
I'll just answer a question. So the one more trick which works for such patients is that we ask them to serve one item at a time. We don't give a plate. Because when you're serving a plate, there are two things. One is that everything is readily available, person eats very quickly. Second is, if you serve the protein first, the fiber first, you ask the patient to finish that first, the stomach is half full. The satiety signals have started. So satiety signals have already told the patient that you should eat less, you're not that hungry. And then by the time you go to the kitchen to get to the next serving, that is the time when you are already feeling that I don't need to eat so much. So these tricks work where you're serving one at a time. So usually like the common habit in the traditional Marathi dish is that in ताटभर rice plate सारखं वाढलं जातं. So that rice plate सारखं जे वाढणं आहे, that is not good for health. At least because everything is available and you can mix and match. It is better to eat one at a time. And in the sequence which Geeta mentioned. So that will make more, you will eat less portion size. Eating in katoris, which is the second thing she said. Eating in a plate versus eating in a small katori. You feel full earlier because you are going to finish that katori and you're going to feel, it's the visual imagery that the body feels that I've eaten one bowl and one plate. These are two different things. So the person feels that he has eaten, even the plate size is going to matter. So you are eating in a smaller plate, you're going to serve less portion. You're going to use a smaller spoon. So a lot of tricks in terms of what you can follow in such cases. And even I don't know about the Ayurvedic principles of when to take water. But if you are filling in water in between, you are also stretching the receptors, you are also increasing the volume of food. So having liquids, so especially for mithai we tell that if you want to eat something sweet at the end of the meal, eat a liquid sweet. Something like basundi or something like a liquid tak, lassi, that kind of a thing, rather than eating a barfi or a peda. Because that volume wise you will eat 3-4 pedas. Instead you will take one glass of lassi. So that is again a trick to help these kind of patients where the sensations are blunted.
Ma'am, how do you detect leptin or ghrelin resistance? I think
Test.
Any tests.
No, you have leptin estimation and ghrelin estimation, but it is not available in standard labs as yet. It is only for research purposes. You do have kits with leptin, but the assay is very labile. Secondly, what they have found is that in polygenic obesity, treating with leptin doesn't make sense because there is leptin resistance. There is the leptin works best in leptin deficient obesity, the monogenic forms of obesity. In polygenic obesity, all the trials have refuted the use of leptin in such patients. So there are leptin receptor agonists which are expected to come into the market in future. Like you have the GLP-1 agonist. You have a lot of molecules in anti-obesity segment which are going to control the appetite. So you have drugs to increase the BMR, you have drugs to decrease the satiety, increase the satiety, decrease the appetite. Lot of, at least there are 90 to 100 molecules in anti-obesity segments which are going to come to help this leptin improve and the ghrelin go down. So ghrelin is a hormone which increases hunger. And in fact, the bariatric procedures, where they are cutting the portion of the fundus of the stomach, those are the procedures which really work on the leptin and the ghrelin. But if you see in terms of the analog, the GLP-1 analogs have some benefit on the ghrelin axis, not really on the leptin axis, and even there is a central leptin resistance. It's a brain leptin resistance, not the peripheral one. So basically, leptin is a molecule which is of lot of research now. We will see some coming data in future, but as of today, we have no implications of leptin and ghrelin, the current state of affairs.
Can I add one thing just because it's the mind-body workshop? I just want to add one thing which is very important. Apologies to you, Geeta. Thing is that we are discussing all the things about the body, but something mindfulness, mind is missing. We have missed what is mindful eating. We are all talking about the mindful eating, but we don't know, we have not discussed what is mindful eating. Even Kowal Zen, his book Mindfulness Cognitive Therapy में resin का experiment करते हैं. We all should know what is mindfulness eating. हमने सुन लिया mindfulness eating क्या होता है, कितना खाना है, कितना देखना है. ये mindfulness eating नहीं है. Mindfulness eating is very very different thing and through the mind. Like when the food आपके सामने आता है, आप उसको अपनी आंखों से देखते हो, उसको सूंघते हो, उसको थोड़ा सा टेस्ट करते हो, आंखें बंद करते हो, that is the beginning of mindfulness eating. So that thing is missing, which we have missed throughout the session. First day में गीता मैम ने बोला था कि आप कीजिए, लेकिन किसी ने गीता मैम की
We'll
बात
talk
सुनी
about
नहीं.
it tomorrow. Don't worry. Yeah, tomorrow we are going to
So-
speak on it.
So
Because
mind
aspect is missing, you're right.
That's missing. That's why we are again coming back to body and body and body
No,
again.
the mind aspect of eating is going to be covered.
Right.
We will discuss
So
mind aspect.
we should wait for tomorrow so
Where
we
we
can
can
cover
do
it.
that.
You can actually discuss and we can initiate that again tomorrow.
So-
you can put your views because we are here to listen and learn.
Could I add the behavioral aspect to it then, perhaps?
So when I teach mindfulness based cognitive therapy to my students, it's very simple thing. We just give them a resin, और रेजिन के साथ में हम आधा घंटा एक्सपेरिमेंट कराते हैं पार्टिसिपेंट के साथ में, और उनका जो रिलेशनशिप होता है फूड के साथ में, जो मैम ने बात किया, एकदम ट्रांसफॉर्म हो जाता है उस दिन के बाद. कुछ बोलना नहीं पड़ता है, आधा घंटा में इट्स काइंड ऑफ रेजिन मेडिटेशन यू कैन से. किसी को बोलते हैं आप हाथ में रखिए, इसका कलर देखिए कैसा है, इसका टेक्सचर कैसा है, ऐसे पकड़िए, उसको खाने में लगभग 10 मिनट एक रेजिन को खाने में लगाते हैं. तो दैट गिव्स अ डिफरेंट एक्सपीरियंशियल थिंग. हम जो बातें कर रहे हैं हमें मालूम है, वो थ्योरेटिकली बहुत सारे लोगों को मालूम है, लेकिन जो मेन चीज है माइंड वाली चीज है, माइंडफुलनेस ईटिंग होती क्या है, कैसे की जाती है. जो फॉरेनर्स हैं हमसे लेके एक रेजिन लेके उन्होंने 6 वीक्स का माइंडफुलनेस कॉग्निटिव थेरेपी बना दिया, उसका 2 लाख रुपया ले रहे हैं सिखाने का. तो वो एक चीज हम सीखना चाहते हैं, हमारे पास शुरू से है. हम
You
मंत्र
were the
का
expert in the resin experiment.
यस
Actually, we
So we
already
use
Yes.
every year.
Last time we did it, but this time we thought the nutrition hacks will help you to understand
that is
mindfulness.
the most important thing, like that
The last year we did
Yesterday,
this.
after she wrote down, we had to say a prayer. That will
Yes.
do our
Gita, so
normal
tomorrow
prayer.
again problem is that we are again coming to body.
And that resin experiment now,
Just got to add 50%
it doesn't
mind.
lead to behavioral change in patients. Do you know that? I used to do that in US with chocolate, dark chocolate. I think it does not lead to behavior change as a sustainable result.
I think Geeta has a lot
See,
of
what the
experience on
environment
this.
is very important.
And,
No, what I mean, I agree with what you say, but at the same time, we are sitting in an environment where we are very well fed. From morning to night, 3 days, we are really well fed. We've been not understanding, am I hungry? I've been exposed to food. So giving a resin, I did that last time, and I observed that there was no thought process because in each of us are here healthcare workers. We know the importance of it. The resin did not give that impact last time. I did with the resin, but then I thought this is good when you in a scenario where you are hungry, you come here to learn, and then because so well fed people will not they'll touch the resin, but internally you're satisfied, you're well fed, your senses are more gratified. So how much impact that resin have will not be very easy to make out, and hence. Definitely mind aspect will be spoken tomorrow, and hence we thought these small nutrition hacks which we discussed, warm water, salad, traditional eating, today's mindless eating, will be able to make us understand, because here all of us are here to be eaten and then we are trying to learn the mindful eating, so the attitude.
There is one very simple hack what I used to do, like यहाँ पे buffet लगा होता है, मैं सीधा प्लेट उठाता नहीं हूँ, मैं पहले सब कुछ देखता हूँ मुझे क्या खाना है, तो सब कुछ देखने का डिसाइड करता हूँ मुझे क्या खाना है. आई डोंट कट एनीथिंग, बट हम क्या करते हैं प्लेट उठाते हैं और आगे के चलते हैं. दिस इज अ वेरी प्रैक्टिकल हैक, राइट. आई एम फॉलोइंग एवरी डे एंड वेयर एवर यू गो. So just I am sharing my experience.
Sure.
I may be wrong
Because
also.
this helps us.
So we have to go around and choose मैं क्या खाने वाला हूँ. अगर हम ये बोलेंगे ये भी खा लेता हूँ वो भी खा लेता हूँ, वो काम नहीं करेगा. अगर हम ऐसा चूज करें 5 चीजें खाने वाला हूँ और एक स्वीट भी खाने वाला हूँ, कितनी खाने वाला हूँ, दैट गिव अस मोर माइंडफुल ईटिंग, क्योंकि बिगिनिंग से स्टार्ट होता है. अगर हम सीधा प्लेट उठा लिया और चल पड़े, वहां से माइंडफुलनेस हम क्रिएट नहीं कर सकते हैं. सो दीज आर द वेरी स्मॉल हैक्स which we can add
we
in
are in
our
a personalized era where we're looking at all this integrating in daily practices. But there's other way around also. I do a survey and decide this is the best I like, and I'll keep space. The Indian attitude कि मुझे आज का ये स्वीट खाना है, 4 गुलाब जामुन खाना है. So I end up eating other things less because I want to just. This is also another attitude which we have. So end of the day, I thought we'll talk more about appetite satiety training, because you come with mindfulness to the buffet. You pick up a plate saying, I'm going to eat only 5 things, I better look a survey. That's, you're already mindful and you're there. But common public, I think there's a lot to be inculcated as awareness, and I think raising is a very good way to teach to the common public. This population here,
माइंडफुलनेस के ऐसा भी हुआ कि सब कुछ अच्छा दिखा तो
तो हमने एक एक चम्मच सब चीज कर लिया. So it is defined differently for each one of us. एक एक चम्मच सब चीज कर लिया.
Ma'am, I also have a question.
Actually, we have learned lot of hacks, you can say. So
Yes.
one is eating protein, second is seeing the food before we go and touch it. And then smell the food, feel the food, and then have it. And visually, it should be eaten first. That's what he meant to say. And I think what Geeta actually impressed upon was that I like that coffee and that dokla thing. That I saw that we had so many hand raised. In spite of being in a mindfulness session, there were so many who mindfully did not bother to not take the coffee and not take the dokla. So it was like after 3 days of learning also, we failed to be mindful, and that's why Geeta thought that resin is not going to work this year. Every year she's been giving raisins and walnuts, and nobody has changed. So, and that is an important fact of which I got to hear from Professor Arya Sharma, who is an obesity expert from Canada, and he did a meta-analysis of all the studies in obesity, whether different types of diets, different types of therapies, different types of medicines, and he said whatever at the end of 12 years, all were the same in terms of weight, all were the same in terms of the metabolic benefits, but those who actively followed this were the ones who were the healthier ones. Who passively followed this, suppose they took medicine, suppose they took XYZ proteins and this, and they stopped taking that, they were not healthy thereafter. So it is, unless you change the biology, unless you cut the stomach, unless you wire the brain, give a ECG to the brain, you're not going to change the circuitry. So the aim is to have this in long run. So whenever we are treating the NCDs, we are telling them, you follow individualized, personalized, these kind of diets. And why she's giving you so many hacks is because you have to follow this for 20 years, 30 years, 40 years. So it is not a matter of doing it for 6 months, 10 months or 12 months. So I have actually seen so many bariatric surgery patients who have come up with 50, 60, 80 kgs rebound. So they have come after 4 to 5 years of bariatric surgery with lot of rebounds. And this is with bariatric surgery. So with medicines, with diet, exercise, with different diets. The same thing, ketogenic diet you were talking. Ketogenic diet, I have seen post myocardial infarctions coming with keto diets. I've seen young males coming with heart attacks after following ketogenic diets. And it is a very, you can say, risky affair to experiment with your body with fat diets. So what here we thought we would teach the principle of healthy eating. So whatever the hacks are, whatever the concepts are, it is to be individualized finally. But what is healthy, what can be done if you can't control appetite, what can be done if you can't feel a satiety, is what actually Geeta has tried to do to her best, and I think you succeeded in that. So give a round of applause for Geeta.
Definitely to improve every year with this.
Definitely there is an improvisation every year.
I want to add one thing.
Yes.
See, when we're going around and we're assessing what we want to eat, I think that itself is not mindfulness. Because we are already judgmental about the food. Mindfulness actually teaches us not to be judgmental. So if I'm seeing Vaishali, I should not see her wearing a black or a red that I like or I dislike. I should just see her wearing this dress. And there's no description that should go into my mind. I should just feel it.
Yes.
That's it. So mindfulness is something, and as a part and parcel of it, I think
Sir was here.
yes.
I would have asked him to speak on mindfulness.
So incorporating it in your lifestyle definitely will work out, and it especially works out for people who have underlying psychological disturbances. I think what all hacks she has given is better. I mean, for people who don't have an underlying psychological disorder, can help us, all of us out, I think, in this workshop to, maintain our behavior.
I think you'll talk more on behaviors. I hope tomorrow.
Yeah.
Behavior. Pani also speaking on eating behaviors also thereafter. So yes, you want to answer. Yeah, please.
I was hoping to add a bit of a behavioral angle to it. I hope Geeta ma'am will correct me if I'm wrong, but the common barriers that we've seen with health choices in general, and this may apply to food, most of the health beliefs models or planned behavior model tells us that there are three things. The first is your perceived benefits and barriers. So these might not be real benefits or barriers. What I perceive as a benefit to making that choice or a barrier towards making that choice. The second is normative beliefs, which means what kind of validation or norm approval are you getting? And this is usually from somebody or people that are, or groups that are significant to you. This can be anybody from a significant other, a spouse, or even somebody that you admire, or so what is the norm? चार चौघ काय करतायत त्याच्यामध्ये implement करणं. And the third is self-efficacy. So how well am I going to be able to follow this? So one of the major choice issues is that I might do this for 3 days, but it's absolutely impossible कि मला हे sustain करायला जमणार आहे. So on behavioral and on a thought level, the self-talk level, these are usually the 3 things that a lot of people face challenges with when they're trying to make a health choice or a health behavior.
I think she's made a very important point of sustainability. So sustainable, whenever behaviors are to be changed, they need to be sustainable. And I think this is the work of most of the psychologists and psychiatrists that we are dealing about. But for us, we tell our patients that is this, I see this very commonly with PCOS. PCOS patients, the mother also asks, Madam, kitne din paresh karna hai? So we are very clear about this कि जिंदगी भर follow करना है. But if I tell them जिंदगी भर तुमको ऐसे खाना है, they are all depressed. So I tell them that let us see how you benefit, how your reports are, and then you go very gradually in disclosing that this is what has to be your lifetime lifestyle change. That is what is very important. So I never say anything about lifetime treatments. I never talk about lifetime follow. It's a slow sort of a change in the mindset of the patient, that the patient will ask you that when will I come, like somebody said in the morning that when will I be off the medicine. That is the time you really start. If you are going to follow diet and exercise for life, you're going to be off the medicine. Otherwise you have an option of taking the medicine. That is the way, at least for PCOS it works. So PCOS, the girls are very hopeful that fertility is one incentive, then pregnancy, marriage, all these are incentives for a young lady. But for menopause, unfortunately, the menopausal women are depressed, they are more negative. This is common patient poor. I'm not talking about general. I'm talking about the attitude of a young woman versus a menopausal woman. So there you have to be motivating also. So there you are going to increase positive psychology along with the eating. Eating should be pleasure for that lady. So that is a major drastic difference in the talking that you do, and that also I think Aarti is going to talk on communication skills. Yes, ma'am.
Also, ma'am, the normative beliefs, I just wanted to add something that this is a huge trend that we are seeing, the Jennifer Aniston salad.
Oh, yes.
Or the Kendall Jenner salad. So it may be something as simple as I'm going to eat what my partner thinks is a good idea for me to eat because he is the source of, or she is the source of validation for me. Or it can be a celebrity where, we have vicarious connection with that, this celebrity eats that salad. So like Geeta ma'am said,
behaviors are contagious.
Yeah, they're
so
contagious.
They are contagious. So if your partner is eating wrong, you are likely to eat wrong. Your partner is exercising, you are likely to exercise. So health behaviors do follow the rule of contagiousness. So it is better that the mother follows that for the child, the husband follows that for the wife, and that kind of.
There's this beautiful, the film is not great, but this incident in Julia Roberts' film where she doesn't know what type of eggs she likes because she's always been eating eggs the way her partner eats them. So after 3 boyfriends, she for the first time makes her own eggs, and this is why I really like what Geeta ma'am said.
Eat, Pray, Love, I think.
No, it was from I think Runway Bride or something. Yeah. But what Geeta ma'am said is that personalization is extremely important because what we perceive individually, the people we seek validation from, and the efficacy that we think we have is extremely important in how we choose and what we choose and the way we choose to do it.
I think friends make a lot of difference to such behaviors because I've seen that when friend is following, everybody is ready to follow. Even the spouse is following, maybe not.
Actually,
yes, I was saying something. You want to say? Okay, Sanjay, you want to say.
I have a question for Dr. Geeta. What is your take on meal replacement plan like Herbalife and all?
Oh, God.
Oh, God.
What do you want me to answer first?
Whether you advocate it or whether it is beneficial.
What is the job of the meal replacement? Is give you a calorie deficit. It replaces your meal. So your meal is defined or undefined. You can keep eating. Like a buffet meal, you eat 1200, 800 calories. And meal replacements is just 150, 200 calories. So if you're very eager to work on weight loss, especially you do it before bariatric surgery, before any surgery, if patient wants to lose weight in a very aggressive manner, that's the time it comes into picture. But it's not a sustainable answer. They do a lot of meal replacements, but they don't know why they are doing it. They do lose weight because at the end of the day it's calorie deficiency, but they are not happy, they are not contented. The chewing feeling, the eating feeling, the satisfaction after eating is not there. They do it for some goal. If they achieve it, wonderful. If they can't achieve it, they go back to the diet. So end of the day, we are doing more harm to the body than good here.
Okay. Thank you.
One more thing that I would
नहीं मुझे सिर्फ एक ही पूछना है कि वेट गेन करने में जैसे कभी कभी 10 साल लगते हैं लेकिन वेट लॉस 3 महीने में करना रहता है
नहीं होता करेक्ट
तो वो जो 3 महीने में करना है इज इट गोइंग टू बी रियली स्ट्रेसफुल टू द बॉडी
So that's why we look more at metabolic change, fat loss more than weight loss, waist loss more than weight loss. It's a very gradual loss which we look at. So metabolism is the goal here, and we say that gradually 1 to 2 kg.
These are the attitudes of
That's again a general
they
population.
are gaining the weight in 10 years and they want to lose it for some function for in 3 hours.
Not sustainable. Okay, I'll come up.
You want to finish saying?
No, you go ahead.
No, I want to say the last word.
Okay, you want to say
Oh,
okay.
There are one point I would like to add is like, we have been talking about like how it's important to have a behavior change for sustainable result. So what I tell my patient, that's what I'm going to share, is if you want to install a new app on old phone, it's not going to work. First of all, you have to update your system. If someone is using like old iPhone, like iPhone 5 or 6, and they want to have current applications to run on it, it will not run. So first of all, make sure you will update your system, and that can be done with your mindset reset. Psychology you have to change. You have to change your micro environment, the people surrounding you, or wherever whatever you are eating, and unless and until you change that, no matter what type of diet you give, what type of behavioral medicines you give, it's not going to work. First of all, make sure that you will change your mindset. Second, micro environment, and then this will be your new system that will help you run whatever interventions will be actually given to you. So this really works.
So, madam, you had something to say.
वर्जन आते हैं अपने पास
Yes.
The last
अपने
one.
सिस्टम
I think Sonal is there waiting for her chance to speak. नहीं बेटा आपका हो रहा है नहीं आप बोल
मैं जो बोलने वाली हूँ ना पूरा उल्टा है मैं लास्ट बोलूँगी
Sonal is able to complain. It's absolutely
I just want to tell you something that if we take out this weight reduction from our heads, we will save so much of time and so much of energy. I don't know when I measured my weight. Today somebody asked me, I don't know what my weight is. Number two, as you said, I am very much influenced by youngsters, and one of them is Shilpa. And I like the way she said about the app, नया ऐप पुराने फोन में नहीं चलेगा लेकिन चलता है मैं बताती हूँ कैसे So let me tell you one thing. So I used to hate oats. Okay, my daughter-in-law, she started introducing healthy food. She's a nutritionist. And I was thinking, मैं क्या बोलूँ अभी मुझे नहीं अच्छा लगता है खाने को. फिर मैंने अपने आप को समझाया नहीं नियंका, it's very good for you. Eat it. Right? Taste one spoon one day. अच्छा लगा मुझे. Second day I had 2 spoons. As I started enjoying the oats, I started enjoying the oats ka chila. And I really enjoyed this the new food. So the new apps are getting into the Number three is your willingness to change yourself. There is a seed, okay? There's a seed and you implant it in a soil. You give water, you give sunlight, you give love and affection, you give all that you want to give. How many of you think that seed is going to sprout? सब कुछ दे रहे हैं उस seed को, लेकिन वो नहीं sprout हो रहा है. उसका क्या reason है? The seed doesn't want to sprout. The reason is it has a shell above it. The shell above the seed is the ego. It is the rigidity with which that seed is put inside. आप उसको कुछ भी कर लो, आप उसको बहुत प्रेम दे दो, आप उसको जो देना है आप उसको दे दो, बट इफ इट्स नॉट हैविंग द विलिंगनेस टू चेंज, इट्स नॉट गोइंग टू बी चेंजिंग. सो माइंडफुल बोलो या माइंड मेडिसिन बोलो या जो भी वर्ड बोलना है बोलो. इफ आई वांट टू चेंज, आई कैन चेंज माई सेल्फ. इट्स नॉट इन विल पावर. आई डोंट कॉल इट विल पावर. इट्स अबाउट जस्ट ट्राइंग टू टेस्ट दैट थिंग दैट अच्छा ये अच्छा हो सकता है. एंड आई लाइक my daughter-in-law's figure, you know. I'm very much impressed by that. She can wear all the tight dresses, and she has made my this kind of clothes for me. Mama, what are you wearing those Prana suits and all that? You got to wear modern clothes. And I tell you, these youngsters are very, 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 very encouraging, and I'm learning from them. And Shilpa, I tell the way she talks, you know, she really makes me laugh, and she inspires me like anything. But I'm just telling that be that seed who wants to break that shell from outside and who wants to really sprout. So you're going to
I think not only Shilpa, I'm impressed by every youngster here. In fact, I'm feeling 10 years younger than what I was when I joined the workshop. So
It's been long time since I've been here.
So she has reduced your age also.
No, I'm not going to share my age now.
Okay, so I think
young मान रहे
who has questions?
I'm younger.
लेकिन मैं एक चीज बोलूंगी, मैं जितने भी यहाँ पे लोग हैं ना, मैं सबसे छोटी हूँ. मैं खाली 16 साल की. मैं हमेशा 16 की रहती हूँ. 16 की हूँ. And that is why I don't have any ego at home, you know. I learn from everybody at home also, from my mother-in-law, from my daughter-in-law, from my son, from everybody I learn. And then I get away with every mistake I make.
I think one thing we have learned from Madam that you should not have a seed cover. You should absolutely be egoless, and that's what she has taught everybody with her. It's just simple, and you can say a simplicity of words and how close she can come to anybody of this age, whichever age she's talking to. She's so closely knit. I never knew her before this workshop. Maybe I met her in few conferences, but I feel like I know her for long now. So that's the way I think that's what is the beauty of such workshops that we're doing. That we feel like a family. You feel that you're so closely knit. You want to be in touch with each other and be very close to each other. So now I don't take much time. Anything else for nutrition? So then,
Sonal.
One question.
I just want your input and ma'am's input on salt intake actually.
Yeah.
Because salt has been very much villainized, and everyone asking restrict salt. In our previous research, we did even for hypertensive patients, 50% will be salt sensitive hypertensive and 50% will be non-sensitive. So, especially in diabetic patient, if you keep on restricting, it will increase their sugar cravings and glucose cravings and keep on eating. So,
yeah, so let me talk to you first on the invisible salt that we eat.
Yes.
So there is huge amount of invisible salt that we are eating every day, which we really don't know. So all your masalas, soups, all your packets which are preserved, all they are salt. So they have preservative salts. So we don't take into account that. What is the normal requirement for salt per person per day? Madam? 5 grams. So 5 grams will be present invisibly in your meal. So unless you are following a fruit diet only, there is most likely chance that with whatever diet you are taking, with whatever foods you are consuming, you are already having invisible salt. So there is no need for an extra salt intake in a normal person, especially if you are a hypertensive. Now, if you are not a hypertensive patient, you can take 5 grams, but it's not 5 grams of actual salt. It's an added cumulative salt. So I think that I agree with you that the salt-sensitive hypertension, especially in the Indian context, is a very common problem. In fact, you see this in PIH and pregnancy in hypertension very commonly. But definitely, cutting down salt is as bad as sugar. Yeah. So it is salt and sugar have the same effect on the body. They are known to increase insulin. They are known to increase aldosterone. They are known to increase water retention. They are known to increase craving. Whether you take excessive salt, it will increase craving. So it is immaterial whether you're taking salt or sugar. So what I tell my patients is, सगळं जे पांढरं आहे ते चांगलं नाहीये तुमच्यासाठी. So मैदा नको, रवा नको, पोहे नको, भात नको, preferably नको. It doesn't mean that you should avoid totally. So they can have once a week, they can have twice a week these items when they want. So I tell Geeta's hacks that 30 days you follow the regular diet and then one day you can cheat. So that I think works for most of them. So in salt, I feel you don't need to counsel on salt. Tell them that you restrict salt. Because as it is, they would be taking a packet of chip will be at least 10 gram of salt. It will not be 5 gram. So you don't know how much they are eating in a day. So what do you think is your salt intake in the meal that we took today? It is definitely more than 10 grams.
Yes.
So I think salt is underestimated by us. So you don't need to actually counsel on salt. In fact, you should tell you those avoid using extra salt. The table salt. Yeah.
I think that is what is each have seen to neutralize the salt.
According to one study, Indian males have approximately 15 grams of salt per day.
And that is why the guidelines have
3 times.
इसलिए नमक का पैकेट जल्दी खत्म हो जाता है.
Yeah. And that is why the guidelines have changed to increase vegetable and fruits. That is why these neutralize, considering your intake, because end of the day, this how many people follow, mindfulness people follow. But end of the day, very difficult to change the population, taste, satisfaction, attitude. Difficult. So step up your vegetables and fruits, especially in such case, step up your fruits. The DASH diet does about 10 servings. That means you need to make a neutralization of it. So actually, this is some answer to manipulate your intake.
मैडम हमको एक वो 10 servings का बताओ. What exactly that means? मुझे वो समझ में नहीं आया. Fruits की 10 servings.
Fruits नहीं, fruits and vegetables together. Generally, it is said 400 gram ICMR Indian guidelines, the NIN guidelines. 400 grams of vegetables. Now, vegetables are categorized to 3. One is normal fruit vegetables, one is leafy vegetables, and one is starchy vegetables. So, 400 grams of vegetable, that's raw. So, if you put 400 grams raw, it becomes a bowl of salad. If you cook that vegetable 400, it shrinks. So, if you eat 2 vati of bhaji in a meal, it takes care of 400 grams of vegetables in a day. It plus says 200 grams of leafy vegetables. Again, that's raw. So if you look at quantitative cooked food, it is normal as we all are eating. It is not something to be scared of. But again, adapted to that 400, 2 bowls of vegetables, 1 bowl of leafy vegetable must every day, right? And 100 to 150 gram of fruit. So this is how the total definition of normal. Now if you have salt sensitive, hypertensive, diabetic, the calculations change plus minus.
So, are we ready for Sonal's session? You all want to have a walk, stand up, dance? 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 Gana lagao
Quick paper pencil task. Yes. And you yourself vouch for your timing. So, this is a nice task for assessment as well as can be modified to intervention. So the instruction would be what's the topic on neuroprotective exercises to make yourself more alert. So we do kind of exercises for the people who are worried. Well, I'm a neuro speech pathologist. I'm Sonal Chitnis. I work as a professor at Bharati Vidyapith, School of Audiology, Speech Pathology. I run a memory clinic there, and I'm more into healthy aging, cognitive aging, and related early dementia, moderate dementias, and severe dementia. How we can work on cognitive reserve building, resilience building, and helping them to work with speech, language, cognition, and swallowing. I'm recently trying to get trained under Phadke sir and Phadke ma'am and the team in MBM. Before that, I'm trained from Nizam Institute of Medical Sciences and the Wisconsin. I was more into brain language mapping and the cognitive rehabilitation. And I'm trying to venture more into helping the people who are aging, helping the people who are having chronic epilepsy, drug-resistant epilepsy, and then my work predominantly is with epilepsy, dementia, PPS, and stroke patients. And yes, I do work. I'm specialized in neuroimmunology in terms of autoimmune encephalitis, like limbic encephalitis. I am here talking to the people who are like a mixed crowd. So I'll try to make it simpler. So all of you play important role in the Indian scenario where you cater to people who may be coming to you for diet, nutrition consultation. Some of you are into pain clinic, some of you are into endocrine and diabetology. Some of you are into the mind-body medicine, importantly from the psychological or physiotherapy or physical fitness angle. So each of you need to understand that cognition is a mainstay. There's nothing without cognition we can do. Even to help people understand what we want them to learn, we require cognition, the mindfulness. and conscience. Cognitivity, circuitry goes beyond that. So there are people who are resonant, cognizant, and going with you. There are people come to you, listen to you, and do not follow that. So a lot happens with cognition. There's no cognition if you don't know the cognition. So with that, I will take it ahead that all of you just take a paper and pencil, take a stopwatch, and check how quickly you can start saying it out, the name of the figure and the color it is in. For example, red circle. No, I want one Hindi, one English. You are a bilingual, so you have a higher cognitive reserve by virtue. If you are a monolingual, I would tell you to continue in one language. Just because you are also healthy aging, but also you are cognitively fatigued. So let's check how fatigued your cognition and then your mental circuitries are. So red circle, Neela. This is bilingual code switching. So वर्तुळ, चौकोन, समभुज चौकोन, त्रिकोण. This is Marathi. Circle, square, rhombus, triangle. This is English. In Hindi, both are chaukon because we don't call it. I don't know what you call that in Hindi. But then you can try switching into the chaukon only. Okay. So then you have a better advantage because Hindi does not have that rhombus as a correct trim. It's very difficult. We are not colloquially even speaking that. So it's difficult for a brain. But you can go with the goal, chaukon, and trikon. Okay? I just conditioned you. So I think let's start. The time starts now. Say it out quickly. Lal. If you are starting with English, then English Hindi. Because some people do not talk Marathi here, right? Start. Lal goal. But that should be English Hindi.
Red circle.
Quick. Time yourself. You identify the color and the figure. I condition them. Now we no cheating. Five seconds over. Stop. So 25 to 30 seconds. A healthy, agile brain till 30 to 40 years with at least 16 years of education, healthy diet, a moderate level of physical exercises should be able to answer with 4 errors allowed. So what we do, there are distractors. There are something written there. So we read. But I told you to just tell me the figure in which color it is, right? So it was clear. You had been having good recency and good conditioning. But you had to switch between the 2 colors and name it correctly. Now all of you try saying this in English only. As all of you are well versed in English. So red circle. Start. Less than 20 seconds, people could finish. So check the bilingual switch. So you all are right-handed by virtue an assumption. If few of you have a left-handedness, so your right brain is more dominant. Now, color identification goes with right, naming goes with left, So you are trying to balance the both functions of the hemisphere, which is very important. It is your frontal subcortical circuitry. So we try to have a person who is not actual early dementia or questionable to get sign of a testing where it will be kind of taxing, but you get to know that how are they feeling. So it can go to 1 minute per person, and then they can actually make many errors. So that is one thing what we can do. Stroop is a very easy task. You can do this in your basic clinics. You could say, if I don't want to do a detailed ACE adult cognition or even a MOCA, if I don't have time, I can tell you Stroop could be helpful, which has non-verbal colors. We are all so biased with the Stroop effect, STROOP. The Stroop effect is a very known neuropsychological test. So it checks your attention, executive functions. So, so I hope you are awake. So I'm Sonal Chitnis. I take this talk ahead in terms of not going to take more time but making it more interactive. So you all see patients in your clinic who are actual patients with some diabetic or blood pressure or some systemic diseases, or some people already have the cognitive decline, which as a effect of age. I'm talking more about the adult neurology in terms of if it is already healthy aging going towards the pathological aging, few are reversible and few are irreversible clientele what you will be able to see. What is important for you to understand that how we need to know the cognition needs to be tested in all our patients, and how we can work on in case they require cognitive rehabilitation. So pro-habilitation is where we do not have actual disease, pathology, name, diagnosed, versus rehabilitation, we call it when actual there is a need of having a person in an early or questionable dementia or cognitive impairment or mild cognitive impairment. It could be amnestic, it could be non-amnestic, and then person requires a rehabilitation. So I'm Sonal Chitnis. I'm representing here Indian Academy of Neurology, Indian Federation of Neurorehabilitation, Indian Speech and Hearing Association. I'm a brain health advocate. I'm to neurorehabilitation. I recently got nominated to WHO as a primary healthcare workstream member. I'm very proud I'm among 6 representing India. So I want to try to work that how mental health is getting incorporated in primary healthcare. So with that, I'm going to join the NCD, Non-Communicable Disease Alliance with WHO. So we are trying as an advocate how we can work on objective of helping the incorporating person who is at risk of developing pathological aging or at risk of developing stroke or at risk of having other NCD, and how he or she can be helped that the disease can be prolonged or it can be delayed or it can be prevented. Now, we all have a very different genetics. We all have different modifiable and non-modifiable risk factors. So, I would try to quickly rush the slides and run through that what is cognition. You all know the brain and the behavior. One has to understand that. But cognition is beyond coordination, awareness, vigilance, awareness about self, awareness about environment, perception, planning, programming, attention, executive function, language, and communication is very important cognitive function. Visuospatial skills of perception, then construction, then your personality, emotions, decision making, problem solving abilities, organization skills abilities. But it's beyond that. You need to understand cognition in much more heterogenetic way, that there are people who are more spiritual, there are people who are very playful, active, very talkative, there are people who are very reserved, do not much mingle, don't have a physical great active life. The people who are actually at risk of developing many immune disorders because of their social, emotional, personality traits, disorders, what they have been carrying and not ready to change. So there are lot differences, heterogeneity, because we being biodiverse with a different cultural background, and we all have our own personality, our own traits with our own different neurotransmitters. We have our own personality to accept, learn, unlearn, change, adapt, and successfully be living. So What is cognitive aging? That as we age, from the birth till we keep aging, how our attention, cognitive functions of language, visual spatial skills, executive control are importantly visual spatial skills of everyday spatial tasks versus learning, unlearning, then how we try to work on problem solving, organization abilities, how that gets affected versus how we try to still maintain it, sustain it. And cognitive aging is somewhere unavoidable phenomenon because we are having a stress with the allostatic load, with the everyday environmental, physical, emotional stress. We have a kind of a factor as a stressor. So if you tend to have good maintained cognitive functions, then over the period, as we age, the attention abilities, our performance on a physical task versus mental task, verbal task, non-verbal task tend to get decline. It could be very subtle. It may affect everyday function, which can be an effect of aging and is age associated, or it can be abnormal. It could be reversible, it could be irreversible. With metabolic aging, also cognition gets affected. So there are many facets to the cognitive aging to understand. So we as allied health professional need to understand that we work in the team of neurocare, neurointervention. So a simple cognitive screen may not pick up the different dysfunction deficits. However, it's important that if at all they are really subtle and can still work, improve, and they are stemming from the metabolic error or they're stemming from the actual cerebrovascular diseases, cardiovascular dysfunction, or autoimmune uh, disorders, or a person with psychological, psychiatric disturbances. So one should understand the normal, subnormal, and abnormal versus normal to the deviant pattern. And the person can be a baseline itself that he or she would say how he or she was performing, how what is affecting him or her, and how we can still work on that. So motoric, sensory, emotional, social abilities in terms of a cognitive sphere needs to be understood. So in this post-COVID era, we need to understand that many of the people have suffered losses, financial, emotional, physical, educational, and with the constraints, something has affected them, especially middle age to the older age. So, WHO recently made this definition of elderly to the old. So, you have young adults, you have young old, you have old. So, how many of you here are young old, and how many could be actually old if we are sedentary lifestyle? So, one has to understand that. But I remember getting the ICMR committee's remark on my one project that you can't say elderly population because I have taken some 20 to 90 years and their swallowing abilities and how cognition affects swallowing is what I was trying to check. And it's important that one needs to understand that with our own cognitive reserve, you all know that when you drive your car or your bike, you all have petrol, your fuel tank on the reserve, and that helps you to still keep going and not getting somewhere halted. So same way, all of us have a reserve. So this reserve needs to be also maintained and built up. And somewhere one has a better reserve to the pain, one of the better reserve to respond to the illness and still work. Like if someone has been running fever and they can still go to work, which is unavoidable, or some duties and they can still do wonderfully. Some people may really do not do the same way. Someone can have the same age, same weight, same body structure, but each of us have a different tendency. So same way, the way we react, the way we respond to the neurological or physical or metabolic disorders are different, and how that can affect cognition is different. So one should understand deteriorating speech, language, cognition, and with that, how it is getting influenced by our mental health, emotional health, our physical health, and is kind of a vicious cycle in many of the neurological disorder. So at present, I feel it's important that when we work on people in your clinics, when they are retired population coming with the sense of kind of a loss or void and not able to get back to the society because recently the person has just lost job or switched the job or not able to function as earlier and then has not been doing well, or could be a person who is actually in search of a better job after the retirement, because many of the people after 60, 65 do not want to sit at home and live the sedentary life. But who can take them? Do they have the same job with the same money, with the same respect? A lot of people I see in the memory clinics now to coming after 45, 50 to 60. So these are the population one should understand that are they worried well versus having a mild cognitive impairment? Are there anything which can be done? So there are somewhere which can understand the social, physical and mental health and emotional health needs to be really worked, understood by a team of medical and healthcare professionals. But in the Indian scenario, we do not have a team present in all the hospitals at all the time, because there could be one speech pathologist, there could be no SLP or no psychologist, there could be no neuropsychologist, there could be no neuropsychiatrist also who can really help run a screen and do the detailed cognitive evaluation. And a GP could be seeing that 90 patients in 4 hours, and then he may not just see that what could be piling up at the back of the mind of the patient who is coming, that he's not performing well, and somewhere the blood pressure and sugar or the any systemic diseases are to be worked also. So I feel that are we somewhere missing, and we need to really work on mild, minor versus major NCD to understand that how a global challenge we can tackle, because we have a huge population. Could be poor, it could be rich, it could be literate, it could be illiterate. So that's how important it is. So all of you have known that cognitive fatigue really makes cognitive performance worse, and how importantly that how cognitive fatigue can really impair someone's performance. In the ADL, it may not, but everyday functioning of independence, it may affect. So, how important it is to understand morning, afternoon, evening, and night. So, adjunct with are the changes in performance, are the changes in behavior, and how the person is able to understand, and stimulability is what we call it. So, I have to check the internal stimulability, that I know my own errors and I try to compensate or try to restore on the same mistakes or errors I made. Versus external internal instability that someone else is pointing out, and then I'm trying to take something positively and then trying to work on that. So it's important that the people who are really fatigued, stressed and performing poor versus people who are actually very quickly getting fatigued, affected and performing poor, versus it's actually cognitive decline which is pathological in nature, which is not picked up on a CT scan or your any other testing. So the cognitive screens need to be really pretty sensitive enough, but it's important that we understand everybody is different, and education, your number of languages you know, then your everyday activity might make you susceptible, cognitively pretty good reserved. There you can actually get a better score. Even the person who I see have my cognitive impairment of amnestic origin, of person with a early dementia, early Alzheimer's, early FTD, or a person who actually has a genetic precursors and the person is having two recurrent strokes, and he can be still better on your adrenal cognition examination, which is widely used cognitive screen. But to get the person on a detailed workup, it may take long. So it's better that we see the person as a whole on our perceptual, executive, and person as a whole history, and MBM can be really helpful. So one should know, one should ask ourselves and the patients and see that are there actually person with cognitive impairment coming to you, and we never take this history. But if they don't respond, they don't tell you that they are having difficulty in remembering, so can you also add people who are not psychologists or who are not into behavior testing? I would say you can still try to add that do you have any difficulty in remembering, do you have any off late performance which is poor on your everyday functioning, or do you of late have some lapses in judgment, lapses in the time management, can be asked in your history taking. And that would be helpful, that if you add to your testing and then make an appropriate referral and see the person can be helped in an early stage and can really have a reversible cognitive decline, which is importantly to be dealt carefully. So your assessment can be therapeutic if you are knowing the person has a reversible cognitive decline versus irreversible cognitive decline, which can be tapped by different test methods. So habilitation and pro-habilitation and rehabilitation I was talking about. So one needs to understand the sensory task, what are the motoric tasks, what are the emotional cognitive tasks, and we'll just discuss in brief about that. So brain health is very crucial and complex. We all are medical and allied health professionals here, and we need to really take into consideration that when you are into mind body medicine clinicians to be, how equipped you are to understand brain health holistically, and are you able to tap it really in our everyday clinics, everyday practice, where we may not have adequate team member at the time when we are seeing the patient or making a referral. If the patient is not from the same city and he or she may not be following up, so we sometimes lose the patient and dropouts. So that could be something what you can work with a therapeutic task, that you can have simple modules, you can give some simple worksheets and send to the person that can you ring me after some time or after some days, after the week, and get back to with this. It could be helpful that we need to understand the pro-habilitation, how early we can tap people. So with that, I can help you understand that we need to understand preclinical stage, questionable cognitive impairment stage, could be early and dementia. It could be importantly that it is MCI, degenerative or non-degenerative disorder, and ahead going towards the mild, moderate, and severe stages of cognitive impairment, which can be of degenerative plus vascular, both origin. We need to understand the mixed pathology, and this could be jargon for a non-medical here. So one has to understand that people who have about 60 years of age and more than 5 years of uncontrolled diabetes, blood pressure, other systemic or metabolic disorders are at high risk of developing early Alzheimer's or stroke, cerebrovascular disease. And it's important that how that can give a rise cognitive decline and can affect the person's everyday functioning and the total wellness or healthy state. It's important that you know the important stages of cognition, healthy aging, age-associated memory decline versus actually converting towards the degenerative and vascular dementia. So, skip this jargon. There are many factors. We discussed that there are modifiable risk factors for cognition to get affected, and there are non-modifiable factors that we have genes and we have our lifestyle. We have kind of a total number of years with the metabolic errors we're living with or conditions we're living with, and then that habits lead towards the pathological aging, and which are susceptible and which brains are not susceptible. It's very different, it's very heterogeneous. So one needs to understand that why mind body medicine, medication and meditation could be helpful. So why did I add this meditation? Because not everybody can do yoga and meditation in a everyday life. I have seen that, but adding that would be really helpful. And not every time meditation is a spiritual mode meditation, but it can be scientific also. It can be done in a different way, which I have been trained, and I always prefer working on a music-based meditation. Because many of our patients who are having aphasia, praxia, poor cognition cannot sit for long, and they do not follow easily the complex instruction. Milder stages people with cognitive decline may actually respond, understand, instruct, but many times when they are moderate cognitive impairment towards severe stages, the meditation, yoga becomes difficult. So there are simpler tasks also. So one can actually modify the task, but in MBM, one can incorporate how we can still instruct, help the person who has cognitive impairment in terms of verbal cognitive impairment, where they cannot understand, they cannot properly execute, they can't sustain, they can't read, write, or they have lost the ability to communicate over the time, but they can still be really mindfully worked in your clinics. So I'm sure this is well covered in these 2 days. My work was very simple by morning stocks and the last 2 days. So I think I'll skip this. You all know the model for your Erickson's model, how you can understand that your physical, mental, and emotional state needs to be known, and how you can work on your team-based assessment in terms of your cognitive circuitry, your affective circuitries, and your behavioral and physiological circuitries, which goes in and out like a vicious cycle, and it has an interdependent circuitry to understand. So we all need to really understand psycho, neuro, endocrine based practice, as ma'am has told, and many of the speakers, eminent speakers have told. So as a allied health professionals, what you should know that take a history in a mindful way and see how you can make appropriate referrals and understand that are there patient been following up or not? Is patient getting benefit or not? Is the patient rightly working or not? Is he actually workable and we are not able to help? So somewhere I feel in Indian scenario, Indian clinicians are having a lot of ego, and when we don't succeed, we don't even refer to outside, we don't even reflect. So it's important that what I've learned from my mentor, that you should always make sure that reflect on your own testing, reflect on how patient has been intervened. And I know we are not in US or other countries, but we can still make our clinical competence much more implicable and much more competently work if we really work on redesigning our models for the different occupation based people with farming or teacher or different background. It's always individualized program. So assessment also needs to be individualized and not just one some scale or one battery could be really helpful. So somewhere having a mindful conversation with the caregivers, with the patient, and then you have to have a clinician perspective, caregiver's perspective, patient perspective, and then see how you can work on designing your assessment of cognition across holistical way for the elderlies who are living alone or they are somewhere in the rehabilitation homes, old age homes, or not been properly cared. This is people who are actually middle aged with the cerebrovascular disease, already having metabolic disorders or stress and affected. Versus, I see some younger population also which are at risk of developing cognitive disorders, and they could be reversible in nature. And few are already having a neurological disorders which are non-reversible but controlled on the medication or have a surgical option. So one should know that what we can design and work on our patient population. So with that, I'll go ahead that we need to give a task on your neuroprotection of the brain, neuroresilience building exercises that we tap spatial cognition. I'm standing here and I know we all have a faulty patterns of standing, sitting, getting up and over the time. So how mindful I am of my own standing. So ma'am and sir and when Dr. Raina had come, I had been somewhere trying to learn the correct way of standing for long while teaching, while working. So how mindful we are while we are standing, while we are sitting, while we are trying to have a wide base. So as Namrata has morning told, so that is partial cognition which will make you aware of yourself. So see that you being PT and OTs would be working more on a spatial cognition. If you work on a therapy which are not taking consideration the cognition, you may not get adequate outcome. So cognitive rehabilitation or pro-rehabilitation goes along with the cognitive aspects where you are making someone self-aware, vigilant. How many times I'm making the same mistake? Am I rectifying my errors? Am I trying to work on that? That's a spatial cognition. Verbal cognition, how quickly I'm able to name, I'm able to remember, I'm able to sign the check, I'm able to remember how much money I'm supposed to do. Am I making mistakes? So in a day, when we have a word retrieval deficits or difficulty in remembering, or when we have a difficulty in recalling the episode, so we all are aging, and as we discussed that stresses, physical stress can affect your cognitive function. So earlier, if I could finish the novel of Sidney Sheldon in 2 days, today I may not finish it in just 2 days. So I think so it's all lot with depends on how you quickly read, retain, recall, understand, and perceive. So making a draft, writing a manuscript, giving a talk, or making a report, all this requires your cognitive ability. So mindfulness, cognition for clinician, and then we can go ahead and make
So,
our
can you
patients.
tell us some skills to improve this?
Have some tasks for him.
I'm asking for example in day-to-day practice. How can I improve on these three aspects: the spatial, the verbal, and the social? One example of each, or maybe some.
It is there ahead.
आणि सोनल पण एकच आम्हाला विचारायचंय फक्त की हे कमी झालंय आपलं हे कसं ओळखायचं दिवसात किती वेळा वर्ड विसरले दिवसात की म्हणजे वो एक बताओ हमको मतलब
Actually, we have a lot of test material, man, but we have Western norms and a lot of rural norms are not there. So it depends again with the person of the medical professional coming to me with the worried well phenomenon that no, I'm not able to do the same way how I was teaching earlier, or someone who is CEO of company or a teacher.
Dr. Sonal, I had one question. I don't remember dates right from age of say 16 years. Does that mean that my cognition is not working at all? Even today I can't remember any date. I don't know what
sir
is the
would be
date.
better person with that. So we all
that makes her a smart person because she this is an interesting phenomena which is called as an externalization of memory.
Yes.
That we say that if there is something which is externally available, what is the need for me to remember that I could put out this. And it's an externalization of some of our faculties to outside devices. So this does happen actually to a lot of people. So you are absolutely right. When I was a resident, I don't know what happened in their time. We thought that a person is disoriented if they can't, tell you the day of the week or the date or the month or in that order you would go. Then you ask person then what is the year, at least you know the year or what the season is. So time is exactly. But now we know, that is altered and it perhaps has this even. So it's not really the loss of memory.
to interpret it very cautiously.
It's inattention to some details which your brain thinks is unimportant.
So 2 decades back, I could remember all the numbers of my family members because I didn't have phone. I got my mobile phone in my internship. But now, if you ask me the phone numbers, I may not remember more than 8 numbers. That's it. So this is what happens. So you have a lot to do with your need, your brain. Use it or lose it, and it just loses it if you don't use that information what you require or not. So lot of tasks for everyday attention, everyday executive control, everyday memory are actually been somewhere been every time performed, worked, oiled and reused, and then they are maintained over the time. And some of the tasks gets lost. So they get affected with a lot of external factors and internal factors. So there are inter and intra individual factors. But if the person says that I never could forget the dates or the day, but it's been like 6 months, 7 months, I'm not able to do that. So that there's something wrong. So one needs to understand the history. What are the stressors? Is that person having the same task and is it only once a week, once a month, or he is really worried and then he is not able to do or she is not able to do. So, but forgetting to add salt in the sabji would be okay, but then forgetting to switch off the gas or light the gas and when the knob is on would be really risky. So we have to understand what is disattentive, misattentive, inattentive task versus completely disexecutive or completely loss of attention, loss of executive function, and how many times the person is doing it repeatedly. Is he aware? Is she able to correct herself or not? On the somewhere you put alarm, somewhere you tell the person to insert that person, you help the person. So if that is happening, that somewhere is important. Now coming to the social cognition, people.
I had a question. One of my friends remembers birthday. मतलब जब एक बार बोला उन्होंने, तो she remembers birthday with month and year, and other things are like normal. And मतलब कैसे relate कर सकते हैं? उसको birthday याद है हर एक मतलब जितने भी है ना उसको सिर्फ एक ही बार बोला उसको याद रहती है birthday और बाकी उसको कुछ ऐसे मतलब normal ही रहेगा.
So selective attention. So what I like, what I want, I would try to give attention, try to recall, and then somewhere work and grasp it better and put it in a long-term memory circuitry. But short-term memories, working memories are really affected. So what I may not like, I may not even pay attention to. So it is a lot in everyday habit. So if I like maths, I would give more preference. I would be very attentive in class. I would quickly solve. But if I don't like the history, science, so it could be subjectivity. It could be children, adolescent, adults also, and it could be changing. It can even say that you pay attention and then say, I want to do it. So there are a lot of factors. Again, one needs to understand that it cannot be abnormal. It could be some way deviant pattern, but not necessarily this is supposed to be considered as abnormal or cognitive decline or cognitive disturbances. So one can have a very heterogeneous clinical picture in inter and intra individual. So for sure, a surgeon doesn't leave Caesar or a navigator in the person's body, right? So it is important that what we do or not. And then we cannot tell someone that I write two medication and the same brand and the same generic item. It's not possible. So one needs to understand that what are we doing, what are we writing, what are we saving, and then it is lot with that person's occupational need. Is it getting affected? Is it somewhere normal, subnormal? Is his or her responsibility getting affected? So that's where one needs to understand the person who coming to you and seeking your help. Are there some cognitive prerequisites to know that they are affected or not affected? So a cognitive screen can help you. I'm just helping you understand that these are the important basic tests of cognition, which are a simple task. With a screener, you can screen, you can ask when you have patients coming to you.
Both being the part of chronic inflammation, whether it is a cognitive impairment and causing dementia. And the other aspect is that chronic inflammation in females, usually there are more chances of getting rheumatoid and SLE. But males are usually found to have more cognitive impairment and dementia. That is my observation.
Actually, I feel that may not be a correct way because I have seen some registries mentioning that females are at higher risk for inflammatory. But the cerebrovascular diseases in our countries are more into male because alcoholism, then tobacco, smoking, and the habits. So there are different patterns, and we not have epidemiological studies backed up because we have Nimans or Chitra or 3 or 4 important registries the data coming from. And again,
menopause change cognition?
Yes.
Yeah.
There are a lot of studies where they say the cognitive decline is there in menopause. But again, it has a lot of effect from the reserve, the person's age, gender. These are the proper independent variable. But then your education, your bilingualism, your physical activity, the social connect, lot can actually somewhere influence the person's.
So it can be distorted.
There's a byproduct brain fog which is created in inflammatory disorders. So that brain fog or confusion is a kind of thing which is definitely is important in cognitive pattern.
Yeah,
So you get to see brain fog in many of the autoimmune workup where the person are not pre-therapy. We always see that in NPH also. So we get to see many of the person with brain fog, cognitive fatigue. So earlier COVID time we saw many patients, even younger adults having brain fog. Yes, sir.
Thank you. Vaishali madam is almost making like a 20-20 match. The last couple of overs, getting the most sensation.
I was getting
This is one of the
this
is one of the most fertile areas in which there could be good original research. I will tell you the reason. Just to continue with, if you all remember, the discussion with Professor Shivram made. He spoke about social cognition and cognition being a very big unmet need in schizophrenia. I remember all that. Okay, now very interesting thing is that the current focus of all the major global pharma companies is on this aspect of cognition. There are 2 types of tests we basically have to understand. One is called as a competence test. Competence means how much competence do I have, in absolute terms. So it's like, globally you have one examination, everybody appears for that examination and you are able to measure the competence. But then we clearly know, that all people's situation, their real life situation is not the same. People have different kind of task demands in their life. So there is a huge battery called as a matrix battery. Matrix battery was a matrix consortium, Sonal would know, or some other people, those who are interested in it. So there's a consortium which generated this competence test called as a matrix. It has several sub-tests in it. There are people who are severe critics of this, because what they say is that it is unimportant, that for everybody, how can everyone have the same competence? What is more important is a usable sort of competence or a usable performance. So, I think, because again, recently I have mentioned to you just in the morning that one of the companies which is very keenly interested in this domain is Boehringer. And the Boehringer's neuroscience guy from Germany, he had come down, we had this discussion because I have long association with this particular domain. I have in fact written some cognition protocols also for some clinical trials. So instead what I think could actually be a very useful thing, that this is one domain wherein you need to work on what is called as erring on the safe side. Because I tell you, there was once a clinical trial and we had the opportunity to make some high quality scans. It was an Alzheimer's trial. And the exclusion criteria was that कि 5 से ज़्यादा lacunar infarct नहीं होना चाहिए. Now it became so difficult, actually to find Indian sample कि जिसमें
subcortical white matter patches.
हाँ, तो अभी उसमें so there is a clear difference, it's not so much of AD, the Alzheimer disease that we are seeing. But we particularly are seeing what typically they would call as a small vessel disease. As a small, आप जो बोले ना sir, whether it could be attributed to the nutritional deficiencies, whether it could be attributed to the physical inactivity, whether it could be attributed to the smoking, tobacco, alcohol, etc. Whatever you attribute it, but one of the biggest contributor to this entire story is diabetes.
Unidentified, uncontrolled. Many people actually are feeling.
So that's why I think we need to err on the side of safety. Perhaps every diabetic need to understand, that there is a risk to get a lacunar infarct. Now, nature's best part is that you never know that which circuit it will hit. If you are unlucky, even a small lacunar infarct in a critical kind of fiber thing also can have an exponentially large effect. It's not a linear phenomena. We need to understand this therefore. It's not that some counts, कि 5 है तो कम होगा और 10 है तो उसका double होगा. ऐसा नहीं है. एक में भी उड़ सकता है. So I think up till now, brain health perhaps did not receive the kind of attention in diabetes which it should have. देखा लीना मैडम बोली global, international, all these things also. You look so much more at the macrovascular complication part. You say the heart is at risk. You say the kidney is at risk. But what about actually the most critical organ, which is the brain? So that's why I say that, brain health in diabetes is perhaps a very, very fertile area in which all of you could look at. We could have, of course, more discussion, debate about it, that what are the ways to go about this. Very often the pattern which is seen in these one is what we call as a step ladder pattern. Barabar na Shivram sir. So you find that suddenly one day there is a deficit. It doesn't happen, in a smooth sort of a decline like as in the Alzheimer's disease. You suddenly find, that a person has some. So flagging, such kind of a changes is something which is very important. We had done a study in cognition in Parkinson's, not although into the diabetes and this particular spectrum. And we found that there was an old psychological tool, old as in it was few decades old, called as a CFQ, Cognitive Failure Questionnaire. Cognitive Failure Questionnaire was more interested in कि daily activities में आपकी dexterity कैसी है. Very simple. Patients and their families could kind of pick that up. And we found that was much. आपके योग study में भी I think in your योग studies also done in these geriatric populations. नहीं I think in those old age homes, correct? ना जिसमें sleep or I think CFQ they had seen. So some of those kind of tools which have not been really into the real mainstream, because people thought that they are of a lesser scientific quality, perhaps may actually be more pragmatic tools, to look at some of these phenomena. As a screening, because screening becomes, very important into all these domains, because once you lose some circuits, then there is a issue. And some people also therefore called it as a vascular depression, because the type of depression which you get as a consequence of, losing some of these circuits in this manner is also pretty resistant to the normal antidepressant
So what
treatment,
is the
etc.
prognosis of that step ladder pattern? Does it recover or it goes
It-
on worsening?
It may stay at the same state if thereafter you get alert, and it's like, we perhaps need to ascribe it the same degree of seriousness which cardiologists ascribe to myocardial infarction. Neurologists somehow have not been so vocal, to kind of call it a brain infarction. We call it chota infarct, pinhead size hai, but it may be in critical locations, it may have risky, thing. And like with one incident of myocardial ischemia, a person gets alerted. So that is how it should happen here. So we need to err on the side of sensitivity. Any change from baseline, most important. Any change from baseline which a person noticed that some task which the person was able to do with ease and is not able to do that. So rather than looking at the absolute competence, look at the change in that person. Perhaps could be one of the useful strategies and paying it adequate importance, like an infarction. And of course, Shivaram sir in the morning he said that there is a good evidence, that you still have the possibility to generate good amount of BDNF at least after you got, one of such small thing. At least after that you wake up, so that you could save the rest of your brain. Otherwise it is just like छोटा छोटा फ्यूज जाते रहेगा, एक दिन बड़ा फ्यूज जाएगा.
And we get to see recurrent strokes. So first ever strokes, people may not have a significant cognitive decline, and they could be like a farmer may not come up with say that his everyday work is getting impaired. He's still communicating, going to farm, working on a same bit. But if it is a pilot, if it is a driver, if it is a railway employee, if it is a truck driver, or if it is a teacher, for sure you need to really ask that what is going wrong. And I feel in Indian scenario, people do not like to tell this. They are fearing that their family members will mistreat or ill-treat, or they will lose their respect. They might lose their job. So there are a lot of these important aspects we need to take into consideration while understanding the cognitive decline, impaired versus preserved ability. So we all have neuroplasticity. So how plastic is our brain? The developmental plasticity makes by virtue that we are quicker, grasping better, learning faster. But as the age increases, the new learning gets affected. So how good you are still doing the better the Sudoku, crossword, or your everyday playing, or the playing games. So it is very important that we understand the history. But however, unfortunately, we do not have that much of time in our everyday clinics. If I have 10 patients and I have to finish in 8 hours along with my IPD cases, it becomes difficult that I may not just spend more than half an hour with each patient. But what happens if being a allied profession, if I don't spend, and then what will happen? That assessment, then rehabilitation, giving home program, following up with a caregiver. So we need to really have a kind of a modules. So here, working pro-habilitation is like you have to really help the person that, okay, you might be at risk to develop. So, but you don't tell this patient that, okay, tomorrow you might develop Alzheimer's or you are at high risk of developing it. So, we can really sensitize people and work on building cognitive resilience is what I'm trying to say.
See, there is recently some studies, actually there's a recent review and there are a lot of old studies which have also said that when you break the news of a patient having mild dementia, the risk of suicide is very high, even if there is no depression involved. So it's also a real world difficult situation because there are multiple risk factors for completion of suicide in older individuals.
So Dr. Sonal, now I think it's 8:30, so we would like to know from you as to how do you identify this person has cognitive difficulties? Is there any tool? And secondly, is there any way to recognize and treat or prevent the deterioration? Because these are what a physician would be interested, because we are not neuropathologists or rehabilitative people. So for a clinician to understand within 4 to 5 minutes, how is there anything simpler that you can guide us in like this slides? Because I'm sure it is dinner time.
You have a screening tool like a Montreal Cognitive Assessment, MOCA. It's a very quick, it's very easy. You can ask the person what is the day, time, date. Why I'm saying about time? Because some people actually get lost about the day and evening. That is actually not normal. So you can pick up. The person says, okay, kiti was sakal, and then they actually look disoriented to the outside the time. So one should understand the day, date, year, month, would be important to understand the person's orientation. It's also helping someone to tap the attention to the person. And you can ask the person, where are you? When did you come here? How did you come here? And if the person has come for the follow-up, then how? Last time when did you see me? Or whom did you see before me? Could be helpful in getting the verbatim in a simple informal setting that is he aware of himself, aware of surrounding, aware of the time concept, temporal concept. So this can be helpful in screening orientation. So there are tasks for each of this. So there is a basic MOCA version. You cannot learn it quickly, and that doesn't require reading and writing and calculation tasks. So people who are illiterate or has a significant difficulty in acquired literacy disorder, we do a MOCA basic, which is a very strong task, which is called visuospatial skill, where you have an embedded figure. So you have 10 figures which are embedded. So you can do the MOCA basic on the person. It takes 10 minutes maximum to screen the person's everyday attention, orientation. Then you give the person 5 words, like I say, झेंडू, झाड, काळा, लिंबू, घर. Can you please recall? दोहराइए. So this is immediate recall, and we tell the person again to repeat that. You say it again, and this is not marked or scored. And after the test, you ask the person that I told you 5 words. Can you please repeat for me? So this is a quick delayed recall task, which is a word learning. Now sentences are easier for remembering. If you tell someone sentences, they have a better redundancy. So a story recall is easier. So you might ask the person that I'm going to tell you one story. Please listen carefully, and then you're going to answer the question. So and so did this study here. Then he liked his girl, and he married in this age. And when he went to other place to start his business, his wife wanted to take a break, and then she started working again. So there are kind of a story recall test from a famous neuropsychological battery of Niemann's, also and CLQT, a Wisconsin battery. And we have a face memory to understand where we can have a right hemisphere tap. There are different brain lobes, hemispheres, and pathways to be tapped when we see the person as a whole cognition. It is not haphazardly just score, but we get to understand the person's brain circuitry, their cognitive abilities. So there are simple screening tests which can understand that patient has impaired or preserved function. With that, you need to carefully understand that, okay, this is the attention deficit and not a memory deficit. Because he is not able to attend, he cannot recall, retrieve, store. So one should understand, carefully interpret the testing. So MOCA is one quick test. You have a simple objects to show. The person has to confront and name. So you have a simple verbal fluency task. In a minute, name as many animals as possible. Start. So how quickly one generate the name. We have a COA task, controlled oral word association. So give me names of animal and home or house objects in a pair. So now, ga, fur, full. How in childhood we used to play, and you go on increasing the pairs, and that makes you work on a verbal executive function. And a person may generate correctly at least more than 2 or 3 pairs, but later instead of animals he will add names of the birds. Yes. So your task can become therapeutic. You can try to work on areas which are impaired, and you can tell the person that, see, there are many apps available online, and work on attention building. So there is a Lumosity free trial for 1 month. There is a Parrot software. So there is a constant therapy software. I don't have time to show you all that. I actually was supposed to do that. So we can work on developing a simple tele module for the person. If the person is illiterate, you have to really work on a person-centered cognitive rehabilitation. Now, as a clinician, what else you can tell? See that you can ask the person to rehearse. See that he writes everyday diary about morning he gets up, writes the date, day, tithi, how many days have happened that the Ganpati festival has over, or that how many days you're going to have next Eid. So you can have a prospective memory task with the everyday attention, everyday memory. when someone has a children abroad. So when did your son last time came to you, and then now when you're going to go abroad, so you can have a kind of a time temporal task with the person and the center do his own life or her own life. You can have a task when the person has difficulty in getting correct name. So see how you can work on category.
Cognitive impairment as a perspective of mind and body or mindfulness. इसके बारे में.
Okay, so mindful. We all have cluttered thoughts. So help the person see what did I ask you, and see that how we can work on person's attention and executive function with the mindfulness, cognitive rehabilitation of attention. We can have the task which I was about to show from a mask is that person is about to go. There are virtual reality models which can help you work on person's attention, that he maintains attention for such and such time, that you can have a loss of attention span in a person. So you can have a simple short goal that you maintain the goal, you talk to the person for long, otherwise the person he might miss the conversation because he is not paying attention. So people, when they are old, they speak again and again the same thing. Sometimes they lose the track. So there is a tangential thought process. So one should understand that in attention, we have different tasks. So how do you develop mindful conversation and communicative effectiveness every day to the person who is elderly in family and wants to have tea, coffee or his milk, and he has forgotten that he has already eaten. Tend to have, in Indian scenario, people feed the elderly first. And when the person already eaten, he feels, okay, I have eaten, but then I'm still hungry. So, you can still work on mindful meal time, mindfulness in terms of he or she has taken his tea or coffee. I've seen many patients saying that my daughter now doesn't give me coffee. And the family does that, okay, she's forgetting. Otherwise, the person can go to bank, do the transaction, can still maintain a good life. So, to make a kind of a diary of what exactly is still impaired and how we can train the mindfulness on everyday communication. That's very important. Everyday attention. It can be different for different people, but ADL attention is important. And again, I would see that how it can be built with the simple app versions, computerized tasks, or worksheets we can give. So, Kodi Sodana, puzzles, or the crossword, or unscrambled task would be also helpful. And we can work on mindfulness in terms of helping the person that, okay, in a day, how many times you got negative thoughts in your mind? What were the negative thoughts? So, I always prefer working on the person's social communication. Social communication requires a theory of mind. If I say this, will that person get hurt? So, pragmatics is the way you use your language. And often elderly people are seen that they do not have a track of if they have hurt someone, if they have worked and then spoken and then forgotten about it. So you need to understand the person as a whole, improve, first assess correctly, see the areas which are lacked, and if you are not able to tap this task on your formal and informal screening, caregivers are the best to give you information, but also take a history from the patient from direct hand. So you can see direct stakeholders to be getting the information from. And involve, not everything you can do or you should be doing. You need to really know that whom you can give the patient to refer to. If they are able to go online, also take some help, also will be helpful, because I'm sure it's not easy for a single clinician to handle everything. And
is there an online app to guide the patient?
Yes.
Which you are showing, if you can play for. You said something, no?
Yeah. Spatial attention, spatial memory, spatial perception task.
I think what Sonal is describing is very core neurological dysfunction related cognitive decline. What we actually see in practice is not that kind of dysfunction. So there are two things that I personally follow in my practice, frankly, and I feel that everybody should do it. That if you have a diabetic patient and you are doing the HbA1c, why are you not doing some kind of neuropsychological testing? What stops you? There are experts available to do it. Get it repeated yearly. The definition of dementia is a steady decline over a period of 1 year.
Yeah, but I need some screening for that. As a clinician, I'm
No, that's
interested
what,
in
this is the
screening.
screening I'm telling you.
So you have to tell us what is the screening.
You refer it. After a certain number of years, you refer.
See, the problem with the entire neuropsychological training is that it is a competence related test. We are looking at something what I think perhaps they are asking, and correct me if I am right, if I get you correctly, is that some kind of a performance related thing which can be very sensitively picked up, so the patient and the family
we don't have
not
anything.
going for a formal testing.
Correct.
But something which they can very easily pick up, and like what we said that, which is like a signal that which should set alarm. Ki, "Arey, ata asa dhala hai na? Let us be careful." See, I tell you, because I had the opportunity to write a chapter on this topic in Geriatric Society of India. They brought out a textbook, so I had opportunity at the time I reviewed this. This also basically actually is a neurovascular phenomena. So it is the autonomic nervous system which is responsible for a lot of these udyog. So and as I said, that normally compared actually to, see again what happens that in the entire cognitive space, there are tests like this, which try to look at memory in isolation, attention, concentration in isolation.
Validity of whatever test we have
Exactly.
in the real world.
Exactly.
So we
In the
don't
real
have a
world.
screening test.
So I tell you what I do, because as part of as part of my neuropsychiatry practice, I get to see a lot of them. These patients constitute actually, in some sense, you can say a fair amount of bulk of my practice. One of the very sensitive things is the way they are aware and interacting with their environment. One of the first things which can easily be picked up is that, is there a change in that? The way they have previously been aware of their environment, the way previously they were taking interest into their environment is perhaps actually is a much more sensitive thing compared to these things. As you rightly said, amchakade like in Dinanath we have a psychologist at the back end. So we tell them कि scan ही करूँगा, memory formality. People also like कि test base नहीं किया, scan नहीं किया, मजा नहीं आया. But most sensitive thing I tell you, and which is of practical significance, is the way they are interacting, with their real environment. Because real environment is something in which they still need to be effective.
So here we are relying on the patient or the relatives?
All three.
We have
take
to
a patient history and caregiver.
Caregiver, both. Because patient with this kind of a problem, generally in diabetes and of vascular origin, have a good insight. The loss of insight and the blunting of emotions and all those kind of thing actually happens in the Alzheimer's disease, as Vani rightly said, which is like a progressive neurological decline. It doesn't so happen actually in this. In fact, the patient is also sensitive. And very often, these are the people who may first present with a mood change. So if a person who had no psychiatric history lifelong, at the age of 65 or 70, comes out with a mood change. It may also present with hallucination also, because depending on which circuit has got it, you suddenly find that and it may be like a pseudo hallucination in the sense that patient has a insight कि हे खरा होत नाही असं पण मला असं असा भास होतोय.
Education is very popular.
So unexplained anxiety, unexplained actually mood changes, unexplained mood changes, unexplained cognitive changes, unexplained actually change in the way person is interacting with the environment are perhaps much more sensitive parameters. Now we are again talking of here it's not a question of academically confirming whether someone has a problem. Now we have to have again the most sensitive test like we were discussing yesterday, a test which is so sensitive that we pick it up and we get alarmed and tell the patient कि चल बाबा थोड़ा ध्यान रख तेरा.
Sir, one more question is this a domain of neurologists, neuropsychiatrists, psychologists, neuropathologists, neurorehab? Because I see a lot of patients with diabetes and these kind of problems. Yes. But I'm really confused as to whom to guide to.
So that's why at the outset I said, in the beginning itself we said that mind-body medicine itself is a relatively a domain wherein the final word has not yet been cast, which means we have a lot of opportunity. Now we are going into the subdomains of mind-body medicine where we have opportunity. In the morning also when Vaijanti madam was speaking, the same issue came up now. That when people have antibodies, what should we do? Should we wait for the frank disease to happen? Because an academic confirmation of diagnosis would happen when the disease would have already progressed. Or should we be alert and react actually, to the first actually onset of the things like that? Okay.
I would put forward that
So-
free
so
therapy you should do a test.
I will therefore, tomorrow, I can tell you that, because there could be possibly be some, people are doing, by the way, that's why the neurovascular type of studies into this particular problem. And I will tomorrow be able to tell you whether there are more advances, have they been able to kind of give more information about that. You want to add something to that?
No, actually, I have not finished my comment. So, my thought is that a routine screening by whatever, actually, the existing screening instruments, so called, they are not actually very valid. By the time they give positivity, it's very late in the day to give any kind of intervention. So, what I generally do is, it is a time consuming procedure, but I send them for neuropsychological testing and I repeat it after a year. So that I find reasonably works. Also doing the activities of daily living, and as Sir said, so if you mentally plot concentric circles about the area of interest of the patient, and if you feel that circle is shrinking, for example, world affairs, the complexity of subjects that the patient is interested in, the number of relatives they go out and actually interact with, the amount of activities they do at home, so many things, if you find that there is a gradual shrinkage in that, that is highly likely that patient is proceeding towards cognitive decline.
That is most sensitive, I would
That is the most sensitive. So these are the three things I get done. Now about the rehabilitation, the most unfortunate part of our culture is that we dispatch our parents into redundancy after a certain age. So the sign that you're taking good care of parents is that they sit in one place, they watch TV, and they do nothing in the house. That is absolutely toxic for the brain. The best advice is for the parents to return to their career. If there is a woman, she should be allowed to cook. She should be allowed to take care. She should be allowed to interact. Social media is considered dangerous by everybody, but it's extremely therapeutic for cognitive dysfunction in elders. In fact, now in the last 2 months, there's a lot of research, and we must teach the elders how to use the social media. Social media helps them to develop social connections, to develop social cognition. Social media is extremely good. In fact, technology is a boon to arrest cognitive decline, because in one shot, technology can provide social cognition, it can provide stimulation, intellectual stimulation, and so many other things. But then, when you're giving, there is a section of elders which you see when you prescribe social media, they go on to mindless scrolling. Now, that when any elder comes with that pattern of use, we suspect cognitive decline. So they just scroll YouTube videos.
I used to understand where
That I have found.
lacking.
Yeah, that I find. So if there is a elderly person who chats and comments on Facebook posts, who has WhatsApp groups in which they are doing some activities, they go for tours and all, they have the logistical, that kind of social media involvement is good. But the elder who is just mindlessly scrolling and consuming the YouTube this thing, that kind of social media is highly indicative of cognitive decline.
But we do see patients who are not much tracking or not having phones and all. So we need to get really understand the people who are poor literate, not into the phone, WhatsApp or Facebook. So we have to have individualized plan. So ask what is impaired. Is it different than the 6 months, 1 year? So taking history is very important. What is somewhere changing the social connect? And then we can have.
In this platform, when we talking about this cognitive subject, I want to have a few words about, like we have the finished about diet and nutrition and everything, where we have started a concept of mindful eating. Similarly, here, if there are cognitive impairment, which are suppose non-vascular, and there are degeneration, inflammation, whatever, whatnot. So I think in this platform, the topic should be mindful thinking, mindful thoughts, good thoughts.
That could be one more session actually.
So I think for particularly when we talk about suppose these cognitive impairment data, suppose there are at present 10% of elderly are being this, and there are about 50% of elderly will be in 2050. So what I aim at, this platform will should start with prevention and primordial prevention to avoid this cognitive impairment in those elderly people.
Early screening.
Yes.
So
Yes.
for that,
So
is it impaired or
we
not?
still have not found that thing.
not there.
Not find that thing.
Because there is a you're absolutely right. In fact, compared actually to the traditional psychological rehabilitation, there are already trials available which compared with yoga, as we said, yoga and meditation being the same, this mindfulness being actually the part and parcel of the yoga process. So even in Alzheimer's dementia, there are studies now which show that yoga perhaps has actually more benefit compared to the traditional way of psychological rehabilitation, which is only cognitively focused. And the main reason is actually the high amount of inner perception, which the person gets and which actually stimulates, the brain. We did a study in Dinanath Mangeshkar Hospital on Parkinson's patient, and we used all the standard test batteries, this, that, etc. Blah blah blah. To our surprise, the best improvement was in cognition. 12 weeks of yoga, best improvement was in cognition compared to any other Parkinsonian domain, but that helped improve the quality of life a great way because the people knew better, to what to do within their limitations. So although they did not improve so much in terms of their motor function, but they became better, because now they knew that how to. The main critical part, as you very rightly said, is the idea called metacognition. Metacognition म्हणजे काय की I know about my cognition and I know how to use it. Why there is so much premium on this so-called first step of meditation called as this inner vision or knowing about self, because कि मेरे पास इतना stock है, then I can decide that how best to deploy जो भी कुछ है मेरे पास में. So that is actually perhaps the key to the whole thing, turning attention inward. Therefore maybe they have never done it in their lifetime, and that's why Namrata is also here, and as Shivram sir strongly recommended.
Dr. Shivram,
Shivram's
is there
immediate-
any study in diabetic dementias or diabetic patients in this fashion?
In the man's any studies? Not yet.
In Bharti, one of the MD students have done that now. There was a 20 patient that they did yoga pre and post, and then they did the
In diabetic patient. Can I add something?
Yes,
So I am running for a senior citizens club for the last 10 years, and how it started was that I was invited by my friend. The battery is gone. So about 10 years back, I was invited by my friend to teach yoga. So I was invited by my friend to teach yoga to a group of senior citizens. This was 10 years back. And it was very far from my house, but I said yes, because I wanted to, this was a new thing for me, so I said okay, yes. And that relationship has been there till today. I was going to teach them yoga, but they taught me so much more, and I was the biggest beneficiary of this because I have a group of people with me with whom I interact. And during the pre-COVID times, I was going there physically. Twice a week I used to go. Morning I used to go for the teaching yoga every day, including Sunday. Somebody was coming, somebody was not coming. But later on I started going also in the evening. तो 15 दिन के मैंने मुझे बुलाया था, लेकिन वो काफी लंबा हो गया, 10 साल तक चल रहा है अभी तक वो. But let me tell you one thing, my YouTube videos are a proof of what work I'm doing. And when I was going physically over there, that time there were very shy ladies, there were many shy men who were not coming forward to speak and all that. And I was the one who was speaking most of the time. I was making them interact. तो वो मुझे बोलते थे कि आप हमको गीता के बारे में बोलो. मैंने कहा मुझे नहीं आता, मैंने पढ़ा भी नहीं गीता. So they knew Gita. They knew Gita by heart. They knew everything about Gita. So I said, आप मुझे सिखाओ. They said, हम गीता पढ़ते हैं, हमको उसके बारे में कुछ नहीं पता है. आप पढ़ो. So they made me read. So I started reading Gita, and I started reading the applications of Gita. Then I started talking to them about the applications of Gita on daily life. But what happened with all of this was that their cognitive was becoming so much better. And when I looked at them, they were like blooming, they were like blossoming, and they were sharing more and more and more and more things with me. And today, if I look at all these people today, the 10-year journey which has come there in my YouTube, if you see, we started singing. You go to them to talk about nostalgia, about their childhood, about their college days. They just blossom like this. And when you make them remember some things in their life, and many of them are having very sad stories. किसी का husband नहीं है, किसी के बच्चे प्यार नहीं करते, किसी ने उनको abandon किया है, बहुत सारी तकलीफें हैं उनको. लेकिन today, when I tell them कि come on, let's celebrate Mother's Day, तो वो लोग गूगल में जाके मदर के ऊपर अपनी कहानियां लिख के, they're so eager for the program. Just last week only I had done about 2 weeks back Mother's Day program. वो लोग पढ़ के लिख के प्रिपेयर करके आके इतना अच्छे से शेयर करते हैं. उनका cognitive has become so much better. And I tell you, the prefrontal cortex now develops only because when we're doing planning, executing, emotions and all of that. बस हमने कुछ नहीं किया, हमने खाली बातें की और हमने connection किया. हमने कुछ नहीं किया, मैंने कुछ भी purposefully नहीं किया था. All what has happened is over a period of time, and the connection part. And when they connect with people, when I tell Mrs. Sumanlata ji, आपने इतना अच्छा बोला, you should see the face and the way it blossoms, the way she starts smiling. So I would say, yeah, these people now, and very brightly said about the social media part. There's a lady who is, I think she is a widow for 17 years. And her complaint used to be that, my husband never praised my cooking in my life. That was the kind of person she was. And today, she takes a selfie, she puts it on Facebook, and we all have to comment on that. And she knows everything. And we did a dance, we first we were doing dance in that room only. We have a senior citizens room. And then she said, ये तो क्या dance अच्छा नहीं है, हम लोग choreographer को बुलाएंगे. Then we called choreographer. Then we started doing the dance, and that steps dance learning, remembering the steps and redoing it. Then she said, अभी ये वाले platform पे किया है ना, अभी वहाँ पे भी करेंगे, वहाँ पे भी करेंगे, because they get lot of positivity, they get some appreciation that pulls them up. So all these things I have seen, in this group of people that I have done the study, they have improved, and memory improve होता है, exactly. The prefrontal cortex becomes bigger, and the negativity has gone down. Initially, when I used to talk to them, when they used to say, ये problem है, हमारा बहू के साथ में ये है, हमारा बेटा नहीं सुनता है, blah blah blah. Now, nothing of that. Nobody talks about that. They're so much enjoying their life, and I tell you that I am the biggest beneficiary because I'm in their company. I become so happy with them. I have learned so much from them, and मुझे ऐसा लगता है कि इनके साथ continue करना ही चाहिए. Lifelong continue करना चाहिए. हमारा cognitive skill भी शायद better हो जाएगा.
Take some simpler indoor game, outdoor game can be helpful. Music can be very therapeutic. So play that. Okay, I can just wind up. So you need to understand that music, aroma, smell, your pictures, your family and the childhood pictures or memories could be actually really helpful for triggering your reminiscence and validation of getting your people up with simple photographs. We will need it. And we can actually have this healthy memory cafes. No, not like a person with dementia, but healthy aging itself is a very important thing to work on. People who are actually aging, it not necessarily has to be having some illness attached.
Virangula Kendra is called.
Virangula Kendra. We have this memory clubs in DMH where we ask people to come and then they spend once a week time and then they give some puzzles, some simple tasks at home. So every alternate day they meet on WhatsApp, sometimes Zoom, and people who are really not much on the phone, they get worksheets. So that could be really helpful in improving the preserving, maintaining cognitive health, holistic, and then getting them all worked up at least once a year is important so that they know that metabolically how are they doing, vascular how are they doing, are they actually developing some other issues which need to be really worked also. So you can have simple tasks like proverbs, idioms. You can ask some jokes that can also make your cognitive work ahead.
Are there some sites for practicing?
Yes, ma'am. So you can have Parrot software, constant therapy, and you can have e-balak task. I'm sorry. E-balak. Flash that e-balak.
Happiness quotient.
No. It's important that you do consider the person how happy he is. It's not nothing to do with your financial status, but then sometimes considering asking the question itself can be helpful. like how you have a CGI, that's how you make how happy, what makes you happy, and they can make that what earlier made you happy, is it still making you happy? Then if not, what else can work? So I always take this work for the cognitive rehab, where people actually can start thinking on what they missed, what they can still take up, restart again. So that level 1. Activity. Activity. Go to memory game. Yeah. So you have so many memory games available online. So this eBalak is kind of one platform which helps. So you have pictures flashed. You have to quickly register them and see.
Don't ask us. Everyone in this room will be dependent.
And you have to click on that. So after 5 wrong, you get a reshuffled picture. So you can have this visual task, you can have verbal task, you can have visual auditory task, you can have instruments, the faces, which is one Salman Khan and one Aishwarya, and see how you can quickly understand. So these are the simple tasks we try to work on a daily basis, how people can work. Then we can ask the person that, okay, can you just make a simple list of in last week, how many times you had chocolate, how many times you had some different food of their choices. So it can be very personalized cognitive rehab program. Sorry.
Thank you, sir. Your task is welcome. That next year's honors list, if you are able to come up with a simple screening sitting in the OPD, which will inform him that this person is at a risk. Which person should go for cognitive testing? So the screening so you do that, okay? You make this task. You do that next year, and your list name will be on the list of honors.
I think I should give a round of applause to the audience. Thanks so much, because really an eye-opener. And we do see a lot of diabetic cognitive problems, and I think we should find a solution. Maybe you also can help us research as to how we can screen them in 2 minutes, 3 minutes. Usually it's also difficult at us. We are not able to. I have actually some inspiration to remember that we are having this problem, and I don't know what to do with it. So that's a big problem. I'm sure in aging diabetic patients remaining alive, this problem will be
Can we have
Please come on, all those who are there and interested in pictures.